or pain or unintentional weight loss or tongue or mouth numbness or immobile jaw and persistent sore throat. Is always associated with the mandible and the floor of mouth or the oral cavity. Okay. If there is a surgical resection, the patient will have speech problem which is going to be very minimal, and restricted mobility of the lips results in lip rounding, difficulty in lip rounding, and closure patient will have that, and bilabial sounds gets affected, and restricted vowel product. When we do the acoustic analysis of speech of an individual with lip cancer post surgically, we'll see that lot of variations in the formant frequencies, because lip rounding is very important for the production of a sound. Imagine if it is a left lateral or a bass tongue, base of the oral cavity, or maybe the posterior aspect of oral cavity. Because of its pain involved in movement of the tongue, individual himself or herself will restrict the mobility of the tongue. That's the impact of the tumor. Because how tumor is going to affect? Because of the restricted mobility of the tongue, speech intelligibility gets disturbed. When the speech intelligibility gets disturbed, individual have difficulty in making others to understand his speech. Because of the presence of the tumor on the tongue, it may be a right lateral or may be a left lateral, or it may be on the anywhere in the oral cavity over the tongue. Once the patient undergoes surgery, whenever we talk about the glossectomy, we always first question comes to our mind is that what kind of glossectomy? Is it a partial glossectomy, or is it a hemiglossectomy, or is it a subtotal glossectomy, or is it total glossectomy? First and foremost, if somebody refers to you for the patient for glossectomy, as saying that this patient has been referred to you for speech and swallowing evaluations post surgery, patient has undergone glossectomy. First and foremost, you as a clinician, you need to know that what kind of glossectomy the patient has undergone. Is it a partial glossectomy? Is it a hemiglossectomy? Is it a subtotal glossectomy, or is it total glossectomy? Depending upon that, you can anticipate the patient to have a problem of the both speech and swallowing. Let us know what is the impact of glossectomy on speech production. We know that tongue is important for the production of fricative sounds. Lateral sides of the tongue has to elevate and protrude further and has to produce a hissing sound for the production of fricative sounds, and linguopalatal contact is very important for the production of the tongue tip sounds. That gets disturbed when the patient undergoes glossectomy. Let us see each type of glossectomy. If patient has undergone partial glossectomy with a primary reconstruction, the problem is very minimal, because only the little amount of the portion of the tongue has been excised, and patient will have a slight distortion of glossal sounds and linguopalatal contact. Sometimes it gets disturbed, sometimes it doesn't get disturbed, and patient will have restricted mobility of the tongue, but problem is not that severe as compared to other type of glossectomies. I have a video, but it doesn't come now. Hemiglossectomy, 1/4 of the tongue, 30 to 50% of the tongue being excised, around 30 to 50% excised. Imagine half of the tongue is excised, reconstructed with different flaps. Tongue mobility is restricted. If the tongue tip sound is affected, imagine linguopalatal contact gets disturbed, patient will not be able to speak the way he used to speak before surgery. There will be a moderate severity. Linguopalatal contact is disturbed. Misarticulation, all the tongue tip sounds which you can see in patients with hemiglossectomy, and airflow is monitored, including the fricatives and affricate sounds also gets affected. Speech intelligibility is impaired because of the presence of the surgery which the patient has undergone. Swallowing problem, oral phase of swallowing is affected, because we know that tongue needs to be moved from right to left, left to right, in order to push the bolus from anterior to the posterior aspect of the oral cavity. Lateralization of the tongue, peristaltic movement of the tongue, it's very important for the pushing the bolus, preparation of the bolus. So oral preparatory phase, oral phase of the swallowing gets affected, individual's quality of life gets disturbed till we start swallowing therapy, and patient is able to get rid of the Rayleigh's tube and start orally. Patients who have undergone subtotal glossectomy, around 70% of the tongue has been excised. Remnant of the tongue is being used along with the other reconstructed flap for the filling the gap in the oral cavity. So the problem will be much more severe than what is expected in a case of a subtotal glossectomy, and patient will have severe speech impairment, speech sound production gets affected, vowels, consonants, fricatives, affricates, and linguopalatal contact, speech intelligibility, speech understandability, everything gets impaired because of the patient has undergone subtotal glossectomy, and swallowing problem is very severe. Think of all the phases of the swallowing: oral preparatory, oral phase, pharyngeal phase gets affected, lingual peristalsis gets disturbed, food bolus preparations, bolus propulsions, bolus transportations, everything gets disturbed because of the presence of the subtotal glossectomy. Total glossectomy is all the more worst. Around 90 to 100% of the tongue is excised. There is no tongue in the oral cavity. Just imagine yourself keeping the tongue in a static position and trying to speak. Keep the tip of the tongue in the floor of the mouth and try to speak, try to swallow. Not possible. But when the tongue is removed, that area has to be reconstructed. Majority of the surgeon, they use what we call it as a PMMC flap. Pectoral major myocutaneous flap is used, reconstructed the defected area of the oral cavity, that is a tongue, and which is adynamic in nature. It only fills the gap in the oral cavity, but does not act, is not a dynamic one. It doesn't move like a tongue. It just fills in the oral cavity. The swallowing problem will be much more severe than the subtotal, hemi and a partial glossectomy. Most of the time patients alone will not undergo subtotal glossectomy alone. Always associated with a radical neck dissection or along with a mandibulectomy and a temporary tracheostomy also. Severe articulatory problems and reduced speech intelligibility, severe reduced resonance gets affected, reduced pitch variability, anti-resonance gets affected because most of the time when they do total glossectomy, they do laryngeal suspension also, and excessive noise, a glutter sound because there is no tongue in the oral cavity. And what happened to the swallowing skills, which I told you, oral preparatory, oral phase, pharyngeal phase, tongue peristalsis, bolus preparations, bolus propulsions, bolus transportations, everything gets affected. For a longer period of time, patient will be on a Rayleigh's tube or a PEG tube in order to supplement the feeding. I have been talking about the different kind of reconstructive along with the major surgery. What are the kind of surgeries? It can be a primary closure, it can be a PMMC, or it can be a forehead flap, or a cheek flap, or tongue rotation flap, or it can be a mesenteric flap, or radial forearm flap. Any kind of a flap is used depending upon the surgeon's expertise and a need which is arised at the time of reconstruction, and the primary defect is going to be reconstructed. The primary defect is going to be reconstructed. That once again depends upon the kind of surgery the patient is undergoing. Based on that, they will do the reconstructive surgeries. You cannot just remove the defect as it is and leave the tongue in the oral cavity. It has to be reconstructed. Imagine without the mandible on the right side, how the facial contour is going to be. Has to be reconstructed. Imagine without the tongue in the oral cavity and just is a floor of mouth. Anything food just goes to the floor of mouth. It doesn't go backwards to the posterior aspect of the oral cavity. Has to be reconstructed. So these are the options available for a surgeon to decide what kind of reconstruction can be used in order to have the primary defect. You can say primary closure and PMMC and radial form, different type of reconstructive surgeries. Now next is the floor of mouth. You can see the lesion here in the floor of mouth. Usually floor of mouth is always attached to the either to the base of the to the tip of the tongue or to the floor of mouth or to the mandibular area. Alone floor of mouth, usually the patient won't undergo surgery alone for the floor of mouth lesion. What has got impact on speech? lesions, tumor, it can restrict tongue movements, making it harder for articulation speech sounds, and particularly front and side of the lateral side of the fricatives and anterior linguopalatal contact gets disturbed, voice gets disturbed, speech intelligibility is affected. Impact once again oral phase, oral preparatory phase, and some extent the pharyngeal phase also gets affected in the lesions in the floor of mouth. Next is a maxilla. You can see the maxilla also is called as a upper jaw. Okay, upper jaw is a place where we said has got a demarcation between the nasal cavity and the oral cavity. Any lesions on the maxillary area can result in impaired speech. Okay, the linguopalatal contact, because patient has to elevate the tongue to the hard palate, to the maxillary area. Because of the pain associated with that, patient will have distorted speech sounds. That's very common regions. Surgical intervention, it can be a segmental maxillectomy or hemimaxillectomy or a total maxillectomy, depending upon the area involved and extent of the disease to the neighboring structure. Resection of the maxilla can result in speech and swallowing and mastication problems. Loss of the anatomical separation between the nasal cavity and the oral cavity results if the maxillary area is not reconstructed. Usually by end of total classectomy. Can I give a piece of chapati to him? Is it possible? Not even a piece of bread, not even a piece of biscuits. It has to be a thickened liquid, because there is no tongue. Tongue, whether 20%, 30%, 50%, 70% is excised, there is no tongue mobility, there is no tongue peristaltic action. Patient finds difficulty to chew and masticate. So you have to decide based on the kind of surgery the patient has undergone and extensive resection of the surgery. Based on that, you need to decide what kind of food consistency can be started for the therapy, during therapy. Any other questions? It takes another
wanted to know the function of the flap. Can we improve the function also?
When we talk about the flap, if it is a tongue rotation flap, okay, sometimes when they do partial classectomy, they rotate the tongue there itself and suture it. So you cannot improve that. If it is a PMMC, if it is a deltopectoral, see there are all adynamic flaps. It just only fills a gap in the oral cavity. It doesn't act as a original structure. So that's a function cannot be restored. Swallowing function can be restored, but flap function cannot be restored. Any other questions from student side?
Radiation, will it affect swallowing?
Definitely it will affect radiation, because most of the patients who receives radiation therapy, most of the hospitals, they follow what we call it as a combined modality of treatment, surgery followed by radiotherapy. When the patient is received it, because that's going to increase thing. Bolus preparation gets affected.
Basically.
Gets affected.
And can we discuss to the radiologist about the amount of radiation?
I have my own doubt that we cannot dictate the dosage of the radiotherapy. because that is not in a purview of the speech pathologist.
So what can be our role in
We can
radiation?
during radiotherapy usually we tell them to come for intensive speech and swallowing therapy. Because of the intensive speech and swallowing therapy, radiation effects can be reduced. If not completely eliminated, it can be reduced. Patient will be much better. Usually most of the on the histopathological examination, they would have decided what amount of radiation has to be given to the patient for how many days. What we can always discuss how the impact of the radiotherapy can be reduced. Like a patient has got xerostomia, they can ask them to give artificial saliva in order to moisturize the oral cavity and the tongue, so that we know that speech and swallowing. You can go for intensive oromotor exercises that will stimulate the salivary glands, and patient will be able to swallow. We can reduce that.
Great.
That's a pre-operative counseling, post-operative counseling is very important. That is how we speech pathologists will be involved in a multidisciplinary team, along with the head and neck surgeon, along with the radiation oncologist, along with the oral surgeon, in order to treat the patient.
Okay, great. Thank you. Anybody else from students?
Anybody else has got any questions?
Basics are also fine.
Just for understanding of the students, can you also briefly highlight about what we can do when the patient has got a trismus?
Pardon.
Trismus.
Trismus.
That's
So
one thing.
trismus is nothing but difficulty in opening the mouth. Okay. How do we measure trismus? Trismus, how do we say that patient has got trismus? If the patient says that I have difficulty in opening the mouth, my speech is not intelligible, I am not able to chew hard, solid food, ask the patient to open their mouth, ask them to insert 3 fingers vertically. It has to be between a 35 to 40 mm width. Anything is less than that, it can be a mild form, it can be a moderate, it can be a severe. Based on that, we are going to say that what kind of problem patient is going to have. Difficulty in opening the mouth less than 10 mm is called as a trismus. So usually we have lot of trismus appliances, and we have separate section of therapy to improve the trismus, along with the major swallowing and speech intervention.
And the second thing is, okay, we are talking about like if the patient has got only lesion in the lips or the tongue and maxilla separately. So what we see in the hospital, actually speaking, we don't get to see only individual site of lesions. So that is one of the important thing that most of the students or even the professionals who will have the doubt when they practice, we talk about we study about each site. For example, if a patient has got lip cancer or the lip resection, then we know what to do. But what we are going to do when the patient comes to you with a complaint of saying that, okay, there is a massive resection where there is a part of tongue is removed, maxilla is removed, and then what we are going to do for that. So that, madam,
Yes,
can you-
true. I totally agree. And if the patient is very sensitive enough to identify the problem, sometimes we do see the very early lip lesions on the lip. So that can be resected. Okay, and each part of the site of the lesion can be taken care. But most of the patients, particularly in Indian scenario, the patient come only with a second stage or a third stage. Okay, they already would have had cancer on the lips, on the floor of the mouth or tongue. Then patient has to what we call it as a commando resection or composite resection or jaw neck resection. Usually they'll undergo excision of the primary site where it is started. I can say it's a tongue, along with neck nodes, what we call it as a radical neck extraction, along with a mandible, some kind of mandibular surgery. The lesions are resected in 3 different areas and 3 different sites are resected. So patients will have much more severe problem compared to the lesions seen alone in the only one particular area. Any questions? Because of the we are running out of the short of time and some problem with technical glitches. I'm not able to complete my presentation. What I have is that I have a mandible, lesions to show, and soft palate becomes oropharyngeal area, soft palate, as well as tonsillar area, and its impact on speech as well as swallowing. How problems can arise? Any kind of surgery done to the oral cavity, as I already told you, not only results a cosmetic deformity, when a functional disability also. Patients will have both speech problems as well as swallowing problems depending upon the site of lesion as well as the extent of lesions. What kind of reconstruction is used? Anything?
Thank you very much, ma'am. We are sorry for the technical glitches here. With that, I would like to thank Dr. B.S. Premalata for the deeply informative and insightful presentation on oral cancer surgery, its impact on speech and swallowing function, and also clearing all our doubts, ma'am. Thank you so much, ma'am. Your expertise and dedication to improving the quality of life for patients through advanced rehabilitation techniques are truly inspiring. The knowledge you shared will greatly benefit all of us working in speech and swallowing therapy, especially in complex oncological cases. We sincerely appreciate your valuable time and contribution to this conference. Please join me in expressing a heartfelt thanks to Dr. Premalata. observing it for 5 minutes. We'll be starting back. Please stay hold.
Video, no photo.
invite Dr. Audiologist at Starkey Hearing Technologies to present their work. Please give them a warm welcome.
Thank you so much. Good morning, everyone. I hope it's morning, yeah. Good morning, everyone. So, I'm Nitish. I work with Starkey, and today I would like to give an idea about our new product, Edge AI. I'll be using simple language so that the audience can relate to it. So before that, I would like to thank the Andhra Pradesh Audiologists and Speech Language Pathologists Association to give us an opportunity to represent ourselves in this conference, and it is a wonderful conference minus the problem that we faced yesterday. So I'll be introducing the Edge AI series of products. Edge AI series of products are nothing but the hearing aids itself. We are hearing aid manufacturers. So it comes in RICs, rechargeable hearing aids, rechargeable custom devices, and the accessories which support the hearing aid and enhance the experience of the device itself. I hope most of you would agree with me that in hearing aids, the most important thing is sound. Patient walks into your clinic or institute or hospital, okay, the first thing they want is the solution to the problem, that is hearing loss. So every manufacturer wants to ensure that they answer that question first to give them, because they have hearing loss, we want to give them hearing gain. But hearing loss is not so simple. Hearing loss is more complicated than what it usually reflects as. And many people use this example that you use spectacles if you have vision difficulty, and then hearing aids are similar. But that's not how it is. If at all you go towards the fovea and then you scratch there and you scratch those cells and spoil it, that's the sensory neural vision loss. That's what is the problem that we are dealing with, and those problems cannot be solved with the spectacle itself. It is beyond that. So therefore in hearing aids we don't do same as spectacles. We just don't give amplifier. We are giving a much more complicated thing to the patient, and we are prescribing sound to ensure that we solve that problem by using that same abnormal system that patient has, which is leading to hearing loss. So to simplify it further, the hearing aids have to have some sort of signal processing, and that signal processor, we call it as a neuroprocessor in this particular hearing aid, and we have to keep strengthening the signal processor over a period of time to ensure that the complicated algorithms can run in that very short period of time, so that you don't have lip sync issues. I say something and you hear it after a delay, those problems should not come. So therefore we need to have a strong processor, and we have kept improvising that. And now we, with our previous generation so-called Genesis AI hearing aids, we were able to do 80 million processings in like a minute, and then with Edge AI hearing aids we are 100 times more faster with that DNN processing. So therefore the electronic industry, that particular research is what is being used to ensure that we are able to deliver such type of processing. But the point is, if you have a processor, it's not enough. We also should be able to deliver sound. So therefore, making use of that hardware, we have something called as neurosound technology that we have named it. And artificial intelligence is all about the way we process hearing. We want the machine to process it the way we do. Okay? So therefore, in order to do that, the researchers have studied how the human is processing hearing, and same way, in the same method, is what we want the digital signal processor to understand sounds. So let's say I'm talking right now, I can hear this fan sound. Even though I did not know that the fan was here, but I'm aware that there is something over here blowing air. Similarly, there is some noise coming from out, there are people talking. Similarly, there is some work happening over here at the back. So all of this is acoustic classification that we are doing at our brain level. Our ear is just the sensor. It is sending information to the brain. Our brain is segregating everything. So we want our processor to be able to do that acoustic classification at the machine level itself and remove the load from the brain and make sure that it gives specific sound so that the people can hear, listen, and make use of the information coming inside of their ears. Okay, so all of that is possible in a much more easier way and in much more faster way, so that if there is wind noise, the hearing aid has to immediately act upon it. Let's say I was walking from here till that door, the hearing aid should not take like 10 to 15 seconds to understand that there was wind noise. I already got wind noise and I'm out. So it makes no sense. So hearing aid has to act fast. So DNN and the fast signal processor helps us identify those different acoustic scenes, and it works as fast as 3 to 4 seconds, so that it identifies, it reduces noise, it enhances speech, and then the patients, the users of hearing aids are satisfied. So we are able to achieve that by using, embedding a neural processing unit inside of the digital signal processing chip that you see in the center. So it works in parallel with the standard processing, and then what happens is it allows for speed and also make sure that the battery life is not affected. If at all there is sound connected, then we'll be able to hear the sample. Okay, so it is too soft in this, I guess. I'll proceed. So basically, by doing so, we are improving the quality of sound. We are improving the sound in such a way that the patient can hear, can converse, and basically the job of hearing aid is, because of hearing loss, the communication gap that is created, we are reducing that communication gap as much as possible and make sure that we are able to help the patient hear better so that they can live better. So much of processing happens in each and every channel inside the hearing aid. So all of these channels are, reanalyzing the environment every 6 milliseconds and making sure that they tune themselves and they classify the scenes, because the situations are dynamic, and they have to keep classifying the scenes to make sure that the patient gets to hear clearly and is able to communicate with their environment. So therefore, the hearing aids are capable of performing millions of, okay, I guess I'm slightly lucky. Okay, I'm not so lucky. So therefore, we do millions of processings of sound, and then if that is not enough, we also have given a switch called Edge Mode Plus to the patient, so that they can add even more DNN to the signal processing, which improves their understanding of speech. So 3 out of 4 patients were preferring the DNN noise reduction over the standard noise reduction capabilities. We also have accessories to move a step further. Whether the patient wants to connect with television or anything, they will be able to do that as well. I would like to highlight this specific accessory because this accessory is like a hybrid between a remote control and a remote microphone, and the patient, for specifically the old age population and all, they'll be even more comfortable to use this accessory in even more challenging situations. We have also made improvements. I'm sorry you are unable to see that clearly, but we have also improved on the connectivity front. The hearing aids can connect with your laptop, with your phones, and so on. Okay, new low energy Bluetooth has been added into this with Auracast facility. We have app that can enable even more benefit to the patients. And we have activity tracking, social engagement tracking. We have balance assessment and fall alerts inside the device as well. In CICs also. I'll skip 2 slides which talks about balance assessment. And yeah, we have a caregiver app as well, where caregiver can monitor the old age user who is old age hearing aid user, so they can monitor it and they can guide them. They can see if they are at home, if they are using the hearing aid completely or not. I'm closing it. We have a wonderful software for the professional so that you can prescribe the sound that your patient needs. You can also demo whether the user controls or the streaming. Tinnitus facilities are also there inside the device, and we have wonderful rechargeable CICs also, so that patients who want the discrete hearing aid plus the convenience of rechargeable, they have it. Our hearing aids are the best in the industry for battery life. Thank God you are able to see the slide. It gives up to 51 hours of battery life on a single charge. They are waterproof, and they are the most feature-rich product in the industry. If you want to know more about this product, then please reach out to us at Starkey. Thank you so much. You missed a wonderful video, actually.
Thank you very much, sir, for your contribution and continued support. If you have any queries and if you would like to know much about these, you can meet sir. Sir will be available just outside, adjacent here. So with that, now I move on to the next speaker for the day, Dr. S. Subramanian. Dr. S. Subramanian is a distinguished, just a second for the technical glitch. Yes. Dr. Subramanian is a distinguished development pediatrician and healthcare entrepreneur based in Chennai. He is the director of Smriti Healthcare and the NISHA Integrated Neurodevelopmental Center, institutions dedicated to comprehensive and multidisciplinary care for children with disabilities. He also leads the NISHA Center of Excellence for Medical Research and Training, organizing major academic events such as AudCon and ENCORE. With an MD in Pediatrics and a Diploma in Pediatric Neurodisability from Sheffield Children's NHS Foundation Trust, he has also earned certifications in various developmental assessment tools. He serves as the National Treasurer of the IAP Growth, Development and Behavioral Pediatrics Chapter and Secretary of the IAP Chennai City Branch. Dr. Subramanian's pioneer work in family-led therapy models, early intervention frameworks, and value-based pediatric rehabilitation continues to shape inclusive care for children with neurodevelopmental conditions. Today, he will be speaking on refraining progress, measuring success in rehabilitation through the lens of the ICF model. Please join me in warmly welcoming Dr. S. Subramanian to deliver his presentation. I now have the pleasure of inviting Mr. Jish Shako and Mrs. Harika to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings.
So I will not be on the stage. I'll be here with you all. I would like to listen to all of you. I would at the outset like to thank all of you wonderful people for giving me an opportunity to stand in front of you and talk. No, I'm a pediatrician, a total outsider in this group of rehabilitation specialists. Most of you are audiologists, speech language pathologists. I saw a few occupational therapists also there. So, I would like to thank all of you for giving me an opportunity to stand in front of you and talk. No, I'm a pediatrician, a total outsider in this group of rehabilitation specialists. Most of you are audiologists, speech language pathologists. I saw a few occupational therapists also there. So it is indeed a good opportunity for me to understand your perspective. The first two presentations that ma'am had done and also this Taki presentation was gave me a different perspective. You know, I'm always involved in pediatric rehab and pediatric care and overall rehabilitation, post-cancer surgery, something that I learned in my undergraduate time, and it was a good revision for me to know how much we have progressed there. Having said that, I was wondering what is it that I can contribute to you all, because I can't sit and tell you how to, you know, read an audiology report or how to deliver therapy, because you are the experts. I'm the one who's learning it from you all. But what is it that we can do is, I come from a multidisciplinary team. I have speech language pathologist, I have audiologist, I have occupational therapist, I have speech therapist, I have physiotherapist, I have genetic counselors, I have social workers, I have general pediatricians, I have neonatologists, I have developmental pediatricians. All these people part of my team. So practicing in a rich group of team, what we come across often is that we have a lot of issues in understanding what is it that all of us are contributing to the individual patient. So to start with, how many of you here have been exposed to ICF model, and how many of you are trying to practice it? Can I have hands up? Ma'am is there. 2, 3. Anybody else? ICF model? The last few rows? No? Because the projection is not good, is it possible for you all to come in front? Because we don't have the LED wall that can reach there. Or I will have to come behind, you know, to ensure that I deliver whatever I'm supposed to deliver. Can you all come in front, please? Can I request the last few rows to come in front? Yeah? Thank you. So, can you go to the next slide, please? You'll be projecting it in the LED wall. Okay, the other question I wanted to ask you is which language you want me to speak to you all in. English is fine. All of you understand Telugu better. What do you all want me to do? Because it's a totally non-clinical presentation. So, oh wow. I am really lucky. So, running 2 conferences every year, I realize that these technical glitches are part and parcel of any conference. So, one need not feel very, odd or bad. This happens in every conference, and it's all part of the game, and we'll have to accept it as it comes. That's nice. Will still operate? Thank you. Yeah. Thank you. So, let's look at a child who underwent physiotherapy because the child is not able to walk. Because the child is not able to walk, we gave physiotherapy and the child has started walking. So, according to the physiotherapist, the goal has been achieved, isn't it? That's what we sent them there for. But the child is able to move, but the child is not able to participate with his friends, with his peers in play. Having not achieved that, what meaning is it for the child to be able to move? This is a question that we all need to keep reflecting as we are working on these children. What is it that we are trying to do here? What is the goal? Is the goal a simple metric on paper? Or is it something that what the child needs to do? These are the questions that we need to answer. So, the question is, how do we define progress? What do we mean by progress here for a child like that? Is it walking or is it participating in play? Who defines a success? Is it the pediatrician who refers? Is it the therapist who handles? Is it the mother or the father who actually pays for the therapy, or is it the child who's actually in the process going through all these problems? And are we measuring what really matters to the families and the community and the child in question? So I'm talking about child. For all of you who are working with adults, you can take it, replace it with the child, adult name. So traditional metrics are of symptom reduction. People like me who treat, yesterday fever was there, or today the fever has come down. Symptom reduction is the main thing. Compliance and correction. Did he take the antibiotics as I prescribed? That is another metric that we usually use. Has this person come for therapy regularly? How is the compliance? Skill acquisition. Is this child able to button? Is this child able to put the things in the pegboard? Is this child able to point at things? That is what you talk about. These are the metrics that we all have. Skill sets that are measured within the four walls of your therapy room. And we have the standardized scores, Bailey, which looks at how the development is, or you have reels or whatever it is that you're using that gives you the metrics. So are these the measures of success? That is a question that we all need to reflect. Next slide. So most of these metrics are disconnected with life. Unless applied appropriately, they are disconnected with lives. They lack any personal meaning. It's a very narrow focus, and the focus is based on what our training is. You are a speech language pathologist, your focus is only on communication. You are an audiologist, your focus is only on hearing. You are a physiotherapist, your focus is not on all muscles below the belt. If you are an occupational therapist, your focus is on hand function. So we have kind of divided the whole thing, where we never put things into the perspective. Next slide, please. So, which is why the WHO had come up with this system, the ICF model of classification of functioning, both in health and disability. So, what does it mean? It's a biopsychosocial model. So, otherwise, we as healthcare professionals, we tend to rely more on the medical aspects, more on the disability aspects, more on the body function aspect rather than looking at the social and the psychological impact of a problem. Next slide. So it has the following things: body functions, what the person is able to do, activities, how he is able to participate, what are the various personal and environmental factors that affect this participation. These are the various aspects that need to be looked into when one is actually trying to look at how this person is having health or not having health. Next slide. So this is a typical ICF model that is usually projected. The center of it is the body function, the activities, and the participation. Now this directly influences the health condition, and the environmental and personal factors indirectly affect the health function through the body function, activities, and participation. And one needs to understand they are highly interconnected, and any variations in one automatically affects the rest of it. Next slide. So this is a very complex concept. When I tried reading this ICF model, it was too complicated for me. So what I did was, I started reading more, and then I found this. This is a wonderful. They simplified the whole ICF concept into what needs to be done on a day-to-day life during our practice. It is called the 6 F words of childhood disability, and I can definitely vouch for it that though it was proposed for early childhood disability, it can be used for later childhood disabilities also, and probably also adapted to adult disabilities. What does it say? It was proposed by Rosenbaum and colleagues through the CAN Child, who have given us a lot of scales, and it is child and family friendly perspective. So it's very easy for us professionals to look at things from a different prism, from a different viewpoint for the whole thing. Next slide. So it looks as function, what a person or a child can do. Family, what is the essential context and the support environment that the child has, and how are they supported. It looks as fitness, which is very important. We often look at a child only from the single point disability. We don't look at the child's overall fitness and body function. Fun, is a child having fun? How many of us have actually spoken to families, tried to find out, is that child in front of you is having fun or not? That is something that we are not asking at all. Does the child have friends? Is the child able to move around? last but not least, any human value, we all as human have hope. We all have hope that the current comes. We all had hope that the LED wall comes up. We all had hope that there are a lot of people sitting here. Hope. Without hope, we can't go to the next level. So if a child with disability has no hope, if the family with a disability has no hope, no plan for future, professionals are able to give that hope, it's not going to be easy. Somebody comes to ma'am's OP with a stage 3 cancer, going to undergo a surgery, and you say, after this, that's it, you can't eat anything, gone. What hope does a person have? That's not how ma'am will counsel. Ma'am will counsel, yeah, you'll have to undergo, it's going to be difficult, but we'll help you. We'll help you through it, isn't it? So that hope is something that we need to also look at. What is it that they have and how can we supplement it? Next slide. So why should we use the 6F? Why can't we just use the ICF? The 6F words translates the abstract concept of ICF. You saw the model, no? Box 1. You understand it as a theory, but how are we going to use it in the next child who comes to the OP? That is what it shifts focus from disability to the strengths and possibilities that the child can have. It encourages a family-driven practice rather than a textbook-driven or a practice that is more oriented towards your assessment scales. So often in pediatrics we used to say, we send for lab reports and then it comes back with some values. It has no correlation with the child. So often we have the dilemma of whether to treat the child or whether to treat the report. You know, the child is fine, but the report says something. Are we to treat the report or are we to treat the child? The same dilemma you will all have. Are you to treat the IQ score that is given by the psychologist, or are you to treat the child in front of you who has much better ability than the IQ score? So this is a dilemma many of you might be having, and that is what we are trying to solve here. Next slide. Where all can it be applied? It can be applied every step. As the child walks in, you can start using. As you take history, you can use using. You can use it when you are planning therapy. You can use it when you are having multidisciplinary team meetings. You can use it when you are talking to parents and trying to counsel them. You can use it for your documentation purpose also. It's a wonderful way to document. Next slide. So I gave you the 6F words. The same thing has been represented in a different form here. Basically, if you remember the 6F and work around for assessment, therapy planning, therapy meetings, documentation and parental counseling, you are a big hit in your community. Next slide. So let's look at few case examples. Next slide. So I have a child, this is actually happened, a 4.5-year-old child, wonderful looking boy, healthy, walked into my clinic who had a sensory neural hearing difference which was picked up early, promptly corrected by the team and is already been on therapy. The child was underwent the cochlear implant, was given the therapy, AVT, whatever it is, and the parents have been very compliant. And according to the report of the therapist, the child has achieved all that it is supposed to achieve in 18 months. Those numbers, those names you all know better than me. So 18 months post-implant, inside the therapy room, the child is able to definitely speak words. Next slide. But the parents are still concerned. And I was concerned too. The mother, as usual, never wants to give up her child. She says, yeah, he talks, but only problem is he does not talk to us. He talks, but he does not talk to us. The father is much more explicit. He's upset that the surgery has not given the results that he wants. He says he prefers solitary play. There is a lot of self-singing and self-engagement rather than interaction with others. And the school says he rarely initiates any peer play. So with this kind of situation, what have we done? Same question. The therapist was given what? Her goals, and she worked on her goals. She gave a report saying that the goals were achieved. But what happens here? Much like what we say in colloquial terms, operation success, patient dead. Okay, so at the end of the day, our cochlear implant is working, but it does not produce the result that we have. Next slide. What did we do? We reframed the goals. We started including a lot of interactive components to the goals and started working with the parents. We started working with the teachers rather than just working with the child in question. And we were able to work around the 6F alignment of the goals around the 6F words, and we were able to achieve better targets. So not that the child started speaking the very next moment, just that our goals are much more aligned and the parents started seeing the results and were much more happy. Next slide. So we had an audiologist, we had the speech language pathologist, we had the occupational therapist and the school teacher involved as a team to work with this child. And without the MDT team, this would not have been possible. Just the ENT surgeon doing the surgery and then going to the audiologist. That is not going to be the way it's going to work. Next slide. Let's look at another child, a cute, bubbly girl, 8-year-old, has had developmental stuttering for some time and had been initiated on therapy from our team itself. There was fluency shaping and articulation drills, and the child had on paper improved a lot. Child is talking much better. Next slide. Parents report that the child is fluent at home but does not open her mouth in the school or anywhere outside. Just avoids any situation where she has to do any group activities or group interaction. Where did we go wrong? So we have once again not worked on fluency and not worked on interaction. She was already having developmental stuttering. She had anxiety. She had low self-esteem. We never worked on that. We only worked on, we identified the disability, we corrected it. But we didn't work on her as a holistic manner. Next slide. So we regrouped our functioning. We started working on activities and participation with peers. We started engaging her in smaller groups and then trying to make her to work in bigger groups. We also went back to her school classmates, her friends, and started giving them awareness about stuttering. Those young children were much more receptive than I'll tell you most of the adults. They were very receptive, they were very helpful, and it helped a lot for that child. So once again, reframing your goals towards the 6F word will change your perspective about how you are going to handle the child. Next slide. So as I said, the psychologist along with the speech language pathologist, school counselor and the teacher were involved in this child. Next slide. Another child, 3-year-old with autism, possible autism with minimal verbal language, had started speaking. We have started giving therapy and the child has started speaking single words, 2-word phrases and all. But it is only within the walls of the therapy. There is no generalization, and the mother feels that in spite of bringing the child across and putting all that effort, it looks as though the mother is invisible to the child, and she finds it very difficult to accept. We once again started looking at functional communication rather than just using words, and we included AAC or using functional gestures during the child's interaction with known adults first. Then we started working with the family, explaining to them the role of AAC, and also started looking at how we can calm the child, provide a more sensory appropriate situation to the child in multiple environments, and that helped us work towards this child's improvement. Child is improving slowly, but nevertheless improving. So what is important in all these cases, next slide, is the fact that one, we need to have a different prism, we need to have a different perspective to the problem than just what is there right in front of your face. A disability, we have to look at how this child is going to be functioning with these skills that you are teaching the child, and we have to work as a part of a multidisciplinary team for us to be able to work on. If you have a single person clinic, you have your own group of occupational therapists or physiotherapists or a group of professionals. You can have a discussion with them. This is what is important. Have discussion with the family, with the child if possible, and with your MDT team to be able to sensitize everybody on what is the possible goals that you need to take for you to work with the child. Next slide. So, having listened to all these 3 kids, what is it that you are going to do tomorrow when you go back on Monday to your OP? That is a question that you all need to reflect. Not tell me, but you all need to reflect. How is it that you're going to approach your patients from tomorrow? Are you going to be the same, or are you going to look at it in a different perspective? Next slide. So families are less concerned about what is the IQ score. Families are less concerned about the numbers that you are stating. They know the numbers only because we give a lot of importance to it. Otherwise, they are more worried about if my child can talk to my father over the phone, if my child can handle a school trip, if my child can make a friend, at least one friend this year, or if the child can tell me if there is something wrong that is happening to the child in the school. Is there any way the child can explain? These are the things that the parents are more concerned. So start looking at it from a parental perspective or a family perspective, and you will start getting the answers. So these are not just parental expectations. Please understand, these are child rights. So as I told you, this is less a clinical presentation, more advocacy. Understand that the child you are treating or therapy that you are providing also has its own rights. And when we ignore that, we are often in big soup. Next slide. So if a child comes to you tomorrow, what do you have to do? So doctor, do you mean I have to change my methodology? You mean I should throw away all the assessment tools that have been taught to me? Do you think I should change the way I am taking class? I should go to the park and start taking class? No, that's not what we are talking about. Next slide. We are asking you to embed ICF in whatever you are doing. Whatever you are doing is important. Measuring those things are important, but also embed ICF into it. Start looking at the 6F words, and then you will start understanding what is the perspective with which you have to look at those same numbers, and then those numbers will make more meaning to you than it was before. So you don't ICF. The other question that I have is there are a lot of challenges. It's very complicated. My system does not, my EMR does not accept it. We have a very complicated, we have a big hospital. It won't enter into that. I can't enter this. Documentation takes a lot of time. Agreed on all these points. But we don't follow a system because it is easy. We follow a system because it is the right thing to do. So if you all know, take home today, that ICF model is the right thing to do, it is up to you to figure out how it's going to work. It's not for me to teach you how it's going to work. So it's very important for you that you understand what is right and start progressing towards what is right, and not keep doing what you know rather than doing what is right is very important. Next slide. So this is something that I did for my team, because they also said, oh doctor, working with you is horrible. One, you don't pay. Two, on top of it, you give us such complicated things. Every now and then you come up with something new. What am I to do? So I gave them a toolkit. One was the ICF based goal planner. Okay, they sit as a multidisciplinary team. I find that OT gives 5 goals. The speech language, the pathologist gives 5 goals. Then the psychologist gives 5 goals. So parent has got 15 goals. And they come back after a month. Amma, what did you do? They gave me too many goals, doctor. I saw it. I got vexed. I kept it aside and I'm doing as usual whatever I'm doing. So many goals for the same child. How is it that the parent is going to be able to work on this? It becomes very difficult. So we had a team goal planner. The other thing that we started working on is a family conversations sheet, which we sit with family to have a conversation when we are initiating therapy. Next slide. Let's go into these. One is the ICF based goal planner, where we had all the ICF domains on one side and started looking at what is the current function, what are the team priorities for the next 3 months or 8 weeks or 6 weeks or whatever you're planning. So you don't have OT goals, you don't have speech goals, you don't have audiology goals, you don't have psychology goals. You have goals for the child. And what are the priorities? And you start working on those as a team. And now you start asking the speech language pathologist, which goals can you help me? OT, which goals can you help me? Oh, you do this, I will do this. Let us work in sync. So those things will come only if you are having a team meeting for it. Next slide. With the family, how do we talk? We go with the ICF model, it becomes very difficult. So we have the 6F words, and we start talking to the parents on how does your child function? What all can your child do now? What do you want your child to do? What is your next? So when you have such conversations and notes, you really know what the family wants. And with this, when you go to the team meeting on setting goals, you are much more equipped on what the family wants also, and you can contribute there. So these two have worked wonders when we use it. I've given it, they use it, but not as consistently as they should. So it is all something that we have to make as an individual certain decisions on how we are going to work on. Next slide, please. So it is very important to conclude that it's a shared vision. It is important. It is not just about learning skills. It is about participation and purpose of that learning. And we also have to see what is accessible, family friendly and actionable for a given child. So let's start framing goals. Let's start evaluating children from the ICF perspective. Don't think ICF is a very complicated one, so I won't touch it. You can simplify it. Start working on it. It will come very easily. Next slide. So Henry Ford had said, coming together is the beginning. staying together is progress, but success is when we are working together. So coming together is a beginning. When we all multidisciplinary, we all have to be under one roof, coming under one roof. It's a beginning. Yes, we are progressing. We are in different departments. We are all co-sitting, same patients is across. That is progress. But when you want success, when you all co-sit together and start working with the child, that's when the MDT becomes a success. So it's very important for us to start working at success rather than just beginning or progress. So please aim for success, and for that a common model will be your ICF model. Thank you for giving me the time. I hope I have done justice to what I have done to.
Thank you very much, sir, for that enlightening and impactful presentation on reframing progress, measuring success and rehabilitation through the lens of the ICF model. Sticking on to your time, thank you very much. Your dedication to advancing early intervention and inclusive care for children with neurodevelopmental conditions is truly inspiring. Your insights you shared will surely help us all improve our approaches and services in this vital area. So now I would like to request our chairpersons to shed the light on the sir's talk.
So I think it was a very wonderful session, and I think it took momentum in 2020, especially the CAN program from Canada.
Yes,
That it has been an excellent thing. My concern is the economy of time. Like we as therapists get mostly 45 minutes, and then there is the work to be done with the child, for the child, and that becomes a concern. Secondly, to have an open door policy that we have been thinking and talking about, also to have parents in the session, and that helps, it goes aligned with the ICF model where the family participation and involvement is involved, but at the same time it takes time, you know, to explain.
Time is a big, time is money, isn't it? So time is everything for you all, and time is the biggest factor. So what I suggest is, when you are planning a day, what we do in our center is, most children don't come in the morning. 9, 10, nobody comes. I have all full-timers. So morning is allotted for the discussions. From around 11 o'clock is when the patients start coming in. So most of the time we start to have all discussions during that time. That is one thing. Second thing, you can have asynchronous discussion also. When you have such clear charts, you can start working on asynchronous discussion. Third, you have 3 specialists: occupational therapist, speech therapist, and behavioral therapist. Let's take an example. Everybody need not sit with every parent with that sheet. One sits and brings in the perspective, it's good enough. That means for every third child that you are seeing as a team, you just have only one person has to see. You will only see for every third child. So there are methods in which you can improvise and work on it. And it will not be all or none. You don't have to take the parent to every sessions of yours if you think that is going to be difficult, because you are not trained to have the parent inside. So you find it difficult. Start taking the parent once in a week at least. So I feel you start making a beginning. Once you making a beginning is 50% of the job done. So start working towards it. It's not going to come overnight. I am struggling in my system. If the minute I walk in for a meeting, everybody is worried. It's like Modi announcing that something is being withdrawn. Same way I will announce something very dramatic and walk away, and everybody has to adapt to it. So they find it very difficult to work with me, in fact. I'm one of the worst persons to work with, because I keep changing the goalpost. So it becomes very difficult for them. But then that is what is progress is all about. We can't sit with the same thing and expect progress.
Sir, I have 2, 3.
Yes.
One was like in 6F, was diet included, food included in any of it?
So when we look at the child's body functions, fitness, automatically diet will come in there. When you want to have fitness, nutrition is automatically included. That's where we work on.
And which model, like multidisciplinary, interdisciplinary, or transdisciplinary, which one?
It's a play of words, sir, according to me. It's up to us what works for us. What I mean by multidisciplinary is, you see, most of the medical colleges or colleges are organized vertically. You understand what I mean? So if I the HOD will send a letter, and that HOD will allot one person there, and then I have to go and see if that time and my time matches. I have to go down. This becomes going up and down. I feel a horizontal system where you can just walk across to the room and talk might be the best way. I don't know what name you want to call it. You call it whatever you want to call it, that works better.
And one last. one last, like not related to ICF, but we are seeing a lot of ads in social media regarding there are medicine for speech. As a pediatrician, what is your answer?
No medicines. No medicines. What what parents mistake as medicines. They come to me. They walk into my OP and say, doctor, somebody told me you are giving medicines for speech, so we have come. Because they are already attending all therapy. I ask them, what is it that you are come to me for? Then they give me this answer. So I tell them, I give nutrition supplements. A nutrition supplement is mistaken as medicine by the parent. And the child, not surprisingly, starts talking because the child is undergoing therapy. You understand what I'm trying to say? The nutrition only is an adjunct to the care. It is not the mainstay to the care. For example, somebody undergoes, let's say you go to the gym today. Okay, every day you're working out. And you also add a protein powder. Definitely your muscle mass is going to go down and your fat mass is going to come down. Now, not by only taking the protein, without going to the gym, are you going to improve? No, you're not going to have. So, let's understand what is the mainstay, what is the adjunct. And then we'll have the idea.
So, Doctor, so since how long you are introducing this ICF?
Over the past 3 to 4 years, sir. It's not completely. Once again, I have to confess, I kept telling that I have introduced it, but people find it very difficult to use. I have to keep pushing, which is why I have made it a point in every conference to come and talk about MDT, ICF, gas scoring system, because these are very important metrics that we need to have.
So, one point, absolutely I accept for that. That is what, so child-based program should be designed instead of looking at the reports, what reports are there. That's absolutely right. The second one I wanted to ask you is the parents. So parents' expectation, you said. So there are parents who have more expectations. We cannot satisfy all the expectations that they have. So because we know what is the limitations there with the child, and the parents, they compare with the child to other child. So my friend's child is picking up very nicely, and why not my child is? So it's very difficult to convince. And moreover, I used to tell my students also, see, 60% of the work will be done by the parents, only 40% only we are as a specialist will be doing. So involve the parents, so then only you can success in your progress. So that is what you are adopting. So really a very good presentation.
As far as the expectations concerned, so the way we counsel them is very simple. When we are talking, when we are having the conversation with them, initial counseling session, after this, the question that we ask is, what is your perspective about what is happening to your child? This is a very essential question that we need to ask. They will give you their perspective. Then their expectations also will be stated. Then you need to recalibrate that to ensure that they, at the beginning of therapy itself, understand what it is. Second, when you are goal setting, you are already saying at 6 weeks the child is only going to do this, so they can't expect anything more. And in my center, they sign off that. So we are very clear on what we are doing. Thank you. I think for want of time, ma'am. Yes, ma'am.
I got a question, sir. The use of ICF framework and intervention strategies like this is very wonderful. It works out because we do use it for head and neck cancer patients, different thing. My question is this, out of the box, how many pediatricians are aware of the speech and language problems seen in children? Because in Bangalore, what we see is that though we have a associations of pediatric association is there, we don't get much referral from pediatricians. We do get from neurologists, neurologists and other allied professionals, but from pediatricians referring the cases, it's restricted. What may be the reason?
Lack of awareness. Because often the common thing that is there is that familial speech delay is a very common problem. So what happens is, my tata spoke late, your appa spoke late, so you will speak late. This kind of wait and watch policy is what is given. There is another problem with the pediatricians, if I can state it here. Problem of time. You have an OP of around 80 children that you have to see per day. You have a child with dengue sitting outside with a platelet count of 25,000. And you have this child walking in, the mother says, is your child talking? He is talking well. Would you go to the next question, or would you say, okay, go with this tablet, come back to me next week, we'll see. Let me call the dengue check. So this problem keeps happening. I'm not justifying. I'm just telling what's happening in the OP. Screening tools are seldom being used. They are wonderful screening tools, but they are seldom being used because of want of time and knowledge. But the awareness has improved a lot. From what we started 8 years back to today, the awareness is much better. I think we'll all progress together.
There are pediatricians who write in the file that 20 session speech, 30 session OT. So, any comments on that?
I think I got caught alone with him. He's bringing out all his problems to me. Sir, with all, I would like to apologize for it, but then I don't know who wrote it. There are such people in every specialty, isn't it? Sitting and discussing about them will be a waste of time for the group. We just leave it at that.
Thank you very much, sir, for answering all our questions. And now we have come to the end. Now I would like to request Mr. Jasti Sridhar to come over for the giving token of appreciation to sir. And I request our chairpersons also to join. Thank you. I would like to request Subramanian sir to hand over the token of appreciation to both of our chairpersons. Thank you. Thank you everyone for your contribution. Now I would like to request Mr. Raju Trika from Labad to give his presentation.
I'm the president of ISHA. Labad is a company who is manufacturing audiometers, para, and recently we have launched our tympanometer. I'm not taking you too much of time. A small video which I'm going to present, in which I want to show you how we have production in our area. This is the production department of our audiometer and tympanometer, where we manufacture audiometer and tympanometer under strict guidance as per the Government of India. This is my company's production department. They are manufacturing both the audiometers as well as tympanometer here. And different levels, checking points are there where the quality of the audiometers and tympanometers and para has been checked properly. This is the live testing. When we prepare our audiometer, it will be kept for live testing for full day, continuously on, so for the testing of the audiometer, so that you get quality audiometers from the Make in India company Labad Asia from international quality. This is our para ASSN line where we are manufacturing our para. We have got two types of para, desktop as well as portable one para. We have two paras. This is our calibration lab where we calibrate all the equipment. This is our RM electronics store where all the electronics have been kept, and it will be kept under a particular moisture and temperature, so that efficacy of each and every product part of the audiometers can be taken care of. So that all has been kept, and this is a area you can see that we are maintaining 19.6 degrees centigrade and 47% humidity, so that all my products should be as per the standards, should be maintained. This is our store. After finish, the goods has come to this place, and then we will display, then we distribute it in the market. So this is our company, the APASLPA Manufacturing. I will request any of you who are visiting Chandigarh, I request you can come and visit this factory, and you can see our office also, and that will be our privilege to attend you when you come to Chandigarh. This is my request. This is my APASLPA. This is the only small presentation we have here. Thank you for spending time for me. Thank you very much.
Thank you very much for sticking on to your time, sir. If any of the participants would like to know more about it, you can go and meet sir. Going on further, now I would like to invite the next speaker for the day. Now I would like to invite Dr. Udit Saxena, a distinguished academician, clinician and researcher in the field of audiology. He currently serves as principal and associate professor at GME RSSOLA Audiology and Speech Language Pathology College under the Ministry of Health, Government of Gujarat. He holds a PhD in audiology from the University of Western Ontario, Canada, and has completed dual master's degrees in audiology and psychology with another in public administration currently underway. He brings a rich professional background, having served in teaching and leadership roles at Ma Institute, Swikar Academy, and even as an audiology tutor in Canada. He has published over 33 peer-reviewed journal articles in top-tier audiology, ENT, and neuroscience journals. His research spans topics such as hidden hearing loss, auditory processing disorders, cochlear implants, and the impact of COVID-19 on hearing. He is also a recognized dissertation guide, conference speaker, and research advisor, and has played key roles in national programs such as RPSK Gujarat, supporting tele-rehab, cochlear implants, and hearing aid distribution. Please join me in warmly welcoming Dr. Udit Saxena to deliver his talk on mechanisms of intracochlear electrical stimulation, electro-neuron interface, and neural encoding in cochlear implants. Claps. I now have the pleasure of inviting Mr. Jasti Sridhar and Mrs. Sailaja to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings. Over to you, sir.
Good afternoon, everyone. First, I would like to thank the organization, Shisha Madam, Sujata, APASLPA CON for having me here. Request to the mentor, just chat me at 40 minutes because this is a vast topic and I will try to cover whatever important things which I can cover. So we are, as an audiologist, we have a big role in cochlear implantation, right? And we make certain important clinical decisions which helps cochlear implant users to perceive sound. But a better understanding of electrodes, electrode length array, electrode interface, stimulation rate, etc., will impact our understanding, will increase our understanding much more, because it will help us make more clear about how the electrical impulses are getting converted into real acoustic experience. So let's start with the presentation. So this is a representation of how the electrodes are placed in the scala tympani of the cochlea. So we'll start with the how electrode array are placed, right? So you can see there are three types of electrode array. One is perimodular, also known as modular hugging electrodes, then lateral wall electrodes, and the mid-discal electrode. So here you can see which, can anyone understand, like, you know, where it is placed and what type of array is that? So in this, it is like placed towards the modulus, right? And when it is placed towards the modulus, it is directly stimulating the ganglion cells here, which is in the horizontal thalal. So it is a example of a modular hugging electrode, right? And the other electrodes were being mid-scala and the lateral wall, right? So this is a complete comparison between the different type of electrodes. They are alternate names. And then the neural targets, these are very important, right? Because perimodular, as I said, it directly stimulates the spiral ganglion cells in the horizontal canal. Lateral wall electrodes, it stimulates the organ of corti, and the mid-scala, it is in the midway, right? And stimulation rate, we all, we have to keep up stimulation rate where the person is start understanding the things. So it is for perimodular because it is hugging the modulus, it is low, and then for lateral wall, it is far from there, it is little bit higher, and for the mid-scala, it is moderate. So there are many things. So we'll stick to this one. Dynamic range is important because it plays a very important role in loudness balance. So for perimodular electrodes, it is wider, which is a very good thing to have a good dynamic range. For lateral, it is narrower, and mid-scala, it is midway. Now, we should know, like, the thing which is going inside the cochlea, what it exactly is, right? So it is a, it has a carrier, right, which is largely a silicon or a carbon nanotube. Nowadays, they are, working on having new materials like alginate and the electrodes and as well as wires which is connected the electrodes to the current supply is there inside it. Electrodes, it should be biocompatible. First of all, it should have higher conductivity. It should material which are currently being used for the electrodes are these alloys like titanium nitride and titanium iridium. The most commonly used is platinum iridium electrodes, and they also come with different coatings to help in various things, right? So because to reduce the trauma inside the cochlea, they comes with a polymer coated electrode to make it less stiff, and with the hydrogel based electrodes. It also comes with the steroid releasing electrodes, which actually help in reducing the inflammation after the surgery. Then to reduce the fibrosis, which is a main factor to increase the impedance after the surgery, they come with dexamethasone and DSL coating. Now, when a surgeon is placing the cochlea is predisposition of trauma, and the major factor of that is stiffness. Okay, and the various things which contribute to the stiffness. Already I told you the electrode contact, their thickness, the wire material which are being used, the insulation material which is being used, the thickness of the wire, and the number of channels which are there. So again, to reduce that, they are having newer materials like CNT and the insulation material like Paraline C. And instead of having straight wires which is connecting the current supply to the cochlea, they start having wavy wires which we see in the medical electrodes. Now moving on to the various type of electrode contacts. So there are three type of electrode contacts. As you can see, the first one is in the form of radial pairs, right? The next one is full band ring, which is a type which encircles the electrode carrier along the array. The next one is half band, which are paired shape and more focused. The first one you find in the medal, the next one you find in the cochlea, and then the last one, the padded shape, is there in the AB. It is more focused, right? they are working on more type of designs. One of the design which they are working on this, octagon star-shaped electrode in order to increase the length of stimulation, the area of stimulation, right? Another thing which they are trying to innovate with the electrode is microplating. This helps in reducing the impedance of the electrode, which again, along with the time is very important. Now we'll see what the role of electrode array length plays. So the main thing is angular insertion depth. Okay, as I was saying, perimodular and straight electrodes. So straight electrodes stimulates the organ of cortile, which is throughout the length of the cochlea. But the perimodular electrodes, which is stimulating the spiral ganglion, it is only till the 1.575 or to 1.85 mm of the cochlea, and that represents the angular length of 660 degrees, right? But none of the modular hugging electrode has an angular insertion depth of more than 390 to 450 degrees. So these things we have to take, keep in mind while you are deciding the electrode for any individual. So in this diagram, various companies, whatever electrodes they are having, so this is representing till what length it is covering. So most of the electrodes are covering the basal return. Some are going up to media, but only the one in the middle, which are metal electrodes, is going to the apical return. So we know like their length is maximum compared to others. Now this is again all the electrodes till what length they goes, and when it comes to insertion, I already told you that it comes in the form of AID. So at what degree, till what degree it can go. So one of the important thing is this buffer length to understand. Now cochlear implant processor, it has a stimulation rate from 70 Hertz to 11.5 Hertz, right? And that values 11.5 Hertz, it starts after 3 to 4 mm beyond the starting of the cochlea, right? So we have to start placing the electrode in the array from this after the buffer length. And why it is important? To get a proper pitch and place alignment. Okay, so in all the cochlea there is a buffer length of 4 mm, so that stimulation starts at 11.5 kHz and it goes up to 7 kHz. Then the number of electrodes. So we think like if electrode or the channels are more, it always gives you better hearing, but it is not the case. Some says yes it does, others says it doesn't. Why? If the number of channels are more, obviously channel interaction will be more. It will contradict with the stimulation and it will reduce the quality of speech perception. And then the distance when you are placing the electrode, it forms it goes under the process of integration with the tissues, and that leaves a gap sometimes. So they say if the gap is more, it is not good. If the gap is less, it is better, right? But then it is also having a conflicting evidence. Some says it will help in speech perception, others says it will not. Then the spacing between the electrode. So spacing between the electrode, it is said if it is more, then there will be lesser channel interaction. Okay, but the problem is more in the apical end, because there channel interaction is more. So the newer electrodes which are coming, they are having higher separation at the apical end compared to the basal end. So for channel interaction, there should less channel interaction is the electrode spacing should be more. Now there is always a confusion between channels and electrodes. Some understand it is like number of electrodes is equivalent to the number of channels. Let's see, electrode are the points where the stimulation is happening, right? And the resulting field is the channel. Okay, and then one electrode is not equivalent to one channel. It can be different thing. It depends on the type of stimulation. In the monopolar mode of stimulation, where the activate their number of electrode is equal to the number of channel. Whereas in the bipolar, if two intercochlear act as one act as stimulating, other as at the ground, the number of channel reduces. Okay, so these are the real channels which are there. Another thing is, instead of having this, then we can also generate some virtual channels with the different type of stimulations. And having this is to improve the speech frequency resolution. Frequency resolution is also very important in speech perception. So if you have an idea about virtual channels, it can help, right? So now there are different ways of producing this virtual channel. The first is sequential stimulation. Sequential stimulation is stimulating two adjacent electrode at the same, after gap duration of 0.5 mm. So there, depending on the amplitude, wherever the amplitude is more towards that side, the audio perception will go. Other method is current steering, where between the two adjacent electrode, the current is divided, and towards the side where electrode current is more, you will get an auditory perception toward that side. The third one is electrode coupling, where the two electrode, we short the electrode between those two, right? And the electric field which is generated is in between those two. So these are the methods where you can generate various virtual channels. Now the most important thing is what we are sending into the cochlea. So those are the signals, right? It can be analog signals, it can be pulse line signal. And analog signals used to be there in the beginning when there was a percutaneous mode of stimulation. So those were continuous with time. All the electrodes were stimulating at the same time, and the amplitude variation comes. It was amplitude variation which is important for speech perception. It was because of the change in the voltage. The benefit was that it is representing the speech sound in a better way, but at the same time, because all the electrodes are getting stimulating at the same time, it was also leading to the interaction, which is again a difficulty in perception. Now the other type of signal is pulsatile signal. Pulsatile signal uses discrete time pulses. It can be presented both sequentially as well as simultaneously. Now let's see some characteristics of the pulsatile signal. So this is down, you can see certain one pulse, right? So the gap, the time for which it is on is the width of the pulse. So that is pulse width. The height of this is in terms of current is the amplitude of the pulse, and the polarity. The first one pulse which you are seeing is positive pulse, which is called anodic, and the other one is negative, which is cathodic. Charge balance, it is also a very important thing. So you are seeing that two type of pulses are there. One is positive, another one is the negative, right? So when you are presenting that in the system, it goes in the form of a train, and the number of cathodic pulses should be equivalent to the number of anodic pulses. Why it is important? Because if any charge is left in the tissues, it can be very damaging to the system. And tissue damage is directly attacking on the lower frequency area, the residual area, which we know, which is very important for the cochlear implant, right? The third thing is the pulse shape. So these two are monophasic, where we have only one phase. The next type is pseudo monophasic. Pseudo monophasic is here. So you have one phase which is with a larger amplitude, and the other one is lower amplitude, but at the same time the duration is more, right? The next one, it is done to balance the charge, which I said, the charge balance, and this is the true charge balance pulse, which is a biphasic pulse. After that comes the triphasic pulse. So triphasic pulse have three pulses. The middle pulse, the first and the third pulse to the charge balance for the middle pulse, which is the important one. Then you have interface gap, the gap between the two phases which is there, and that gap is important because, as the scientists are just saying that if the shorter interphasic gap is there, then the neural responsiveness is better, and the thresholds are lower. It is always good to have lower stimulation threshold. Now pulse is 1 second. So 1 millisecond, 1 minute is equivalent to 100,000 milliseconds. So 1 millisecond, if any pulse is there, then the stimulation rate is 1000 pulse per second. And how many pulses are there within one, the pulse rate, how many pulses are there, and then what is the duration of each pulse. Based on that comes the pulse strain duration. Now once you have the pulse, then that pulse only is being used to impose the incoming signal, and that is only delivered to the electrode. So speech can be speech and sine waves. This is an example of a pulse strain which is being modulated by a sine wave, where modulation encode amplitude variation of the time, and modulation indicate degree of amplitude variation. Moving on to the stimulation pattern timing. Now timing is in terms of whether the stimulus which we are presenting are overlapping or it is not overlapping, right? So first one is sequential stimulation, which is non-simultaneous stimulation. So you are seeing various electrodes are there, and it is being delivered at the different times. So it means that the pulses are delivered at a different time and they are not overlapping. Now the time gap between that is important. If the shorter time gap is there between the delivery of the two signals, then it has a summative effect. It will lead to over excitation sometimes, and if it is a long interval, it will cause forward masking. With this type of stimulation, channel interaction will be less, and that's why it is more preferred in the speech processing strategy which are being underused nowadays. Other type of stimulation is simultaneous stimulation. Simultaneous stimulation, all the electrodes are activated at the same time. Now this can be done with both analog stimulation as well as pulsatile stimulation, right? Now when we are sending two signals and the current is matching, they are in the phase, it will lead to excessive stimulation. If we are sending the signal but if they are not in phase, then it will lead to lesser inadequate stimulation. So that's why having a knowledge of that is important. There is again a partial stimulation where two electrodes, three electrode pair is there which is widely apart. Those are chosen, they are stimulated at the same time, but then the different pairs are stimulated in sequence. So that's why it is called as partial simultaneous stimulation. Moving on to the coupling, because what is happening inside the cochlear current. Okay, current passes between the two centers. Any reason, it has to be a loop, right? So we have to have a activated electrode and we have to have a ground electrode. Now ground, these two electrodes, when they combine, it is called electrode coupling. The various ways how it is being coupled is number one, monaural stimulation. In monaural stimulation, one intracochlear electrode act as an active electrode, whereas the ground electrode, which is also called as return electrode, is extracochlear electrode. So the loop is formed like that. Then the other one is pseudo-monopolar stimulation. In that, both ground as well as active electrode are within the cochlea, which is there. Then the common ground. In common ground stimulation, there is one active electrode and all the other electrodes are short-circuited to form a single return electrode. So, and depending on that, the current flows. Where if the active electrode is towards the base, the current flow is from base to apex. If the active electrode is at the apical side, then the current path is from apex to base. After that comes the bipolar stimulation. Bipolar stimulation is having two electrodes, active and return within the cochlea, and then they are how much they are separated. If it is bipolar, then bipolar plus 1, it means it is separated by one electrode. If it is bipolar 1 plus 2, BP plus 2, then it is separated by two electrodes. So it is a representation of the first one is the representation of bipolar plus 1, right? The E1. And here monopolar stimulation, it has the widest range of stimulation, and for that's why stimulation rate threshold is low. Whereas bipolar stimulation, it is the narrowest the narrowest area is stimulated, and that's why the thresholds here are relatively higher. Then there are other stimulation like tripolar stimulation, partial tripolar, tripolar stimulation, one active electrode and the two adjacent electrode act as a return, where the current is divided when the current is going away, right? So then the current is divided between the two adjacent electrode. In the third one, it is tripolar stimulation. It is a combination of the tripolar as well as the monopolar stimulation. So current again is divided into one half goes to the external extracochlear electrode, then the adjacent adjacent to the half of 1/4 goes to one and 1/4 goes to the other. That is how current distribution takes place in the partial tripolar stimulation. These are the various stimulation which we have. What is the current need? Current need is very important. If we have lower current need, it will the battery will goes on for longer time. If it is high current needed, so this helps us in maintaining the battery life. And now when we are discussing about the current and everything which is happening in the cochlea is because of the current flow, so it is important to understand these aspects as well. What is voltage? So voltage is actually the difference in the potential between the 2 points, and it is actually the work done to transfer current from one point to another point. Current is like velocity. It is the rate at which the current is flowing. Impedance, which is we calculated on a measure it on a daily basis with cochlear implant. This is the opposition to the current. Okay. So it is the opposition to the current at a specified voltage. Now, why it is important? Because all the things are contributing to the impedances. Now, resistance, when it comes to resistance, it is for the DC circuit. When it comes to impedance, when we use that word, that is for the AC circuit, and it has both magnitude as well as phase. And actually, if you see in the electrode impedance, it is a vector sum of the resistance and reactance. Now, resistance, which part of the electrode contributes to the component of the electrode that contributes to the electrode resistance is electrode contact, then the lead wire and the surrounding media, and the other one reactance, which is also known as polarization component. The contributing factor is the interface between the electrode and tissue, right? So these two, and this is the circuit which is formed. So it is in series, and the interface act as a capacitive, which stores energy and restrict the flow of current. So all these together contribute to the electrical impedance. When we are measuring it, we get the values, right? But how the system measure it? System send a current to a particular electrode, and it measures the voltage change between the active electrode and the current and the ground electrode, and that is the value which we see on the screen, right? And what stimulus is being used for that is lower level biphasic current pulses. If what leads to the electrode change over time, number one, at the time of surgery it is low. Post-operatively it goes higher because the fibrosis happen, and then with the stimulation again it will come down, but then it has to be constant. Of that particular electrode, or there can be reimplantation trauma, inflammations, and if it is a decrease, right? In the increase there can be open circuit as well. If there is a decrease in electrode impedance, that can be short circuit as well. Now this is the very higher. So that happens when the loop is broken somewhere. Okay. And this is the short circuit. Short circuit is when two conductive component of the electrode array get attached to each other, and that happens usually when there is a curling of the electrode, or there is a break, somewhere it got clinked, and at that time what happens, impedances goes very low. This is very important because the short circuit and open circuit we can see on the screen, but what we don't see in the measures usually is the partial short circuit, and it happens when crack just started. What happens at that time, the perilymph start ingressing the electrodes, and because of that over time impedances come down, but it doesn't come down at the moment. You must be seeing many kids that suddenly will say, he stopped wearing the electrode. So sometimes check for this. Obviously speech perception will go down, but the main thing is patient refusal to battery devices suddenly when he is using and suddenly. But this measure, usually the system, it doesn't measure that, right? It measures short circuit but not the partial short circuit. Clinical use, we get to know which electrode is working or not, which is open, which is short. It also helps us in mapping the devices, okay? No problem. So there's a lot more. Let me talk about, ECAP. This is another thing which you measure. The other one, see, this is telemetry. But when reverse telemetry gives you these measures. The middle, which I didn't show you, were based on when reverse telemetry was not there. Okay. So let's see the ECAP. What is that? So ECAP is a negative deflection and a positive deflection. Okay. So it's like the first wave of AVR, right? But because we are doing the measure in the cochlea, so that's why this is the ECAP is larger near field version of the first wave of AVR. Latency is important, so the N1 should come around 0.2 to 0.4 millisecond, and the P2 should come around 0.6 to 8 millisecond, and various companies has different names for it. So don't get confused, it's in the end ECAP. This is important. So ECAP, it is an algorithm which shows you that it is there or it is not there. But to have a better understanding of ECAP, we should look at the morphology of it and the growth function, how it is growing, the slope of it. Okay, because the slope gives you many indication. It also gives you an indication of neural rate of excitation. See, you are, recording the electrode, which is 2 electrode away from the active electrode. Okay, but if you start measuring at the 3rd, 4th, 5th away from the active electrode, it will show you till where the neural excitation has gone. So this is the activated electrode, and you can see as it is going towards this side and that side, neural excitation is decreasing. So it will show you how much one electrode contributes to the neural excitation of the other one. I think there is a lot more, but for this session I have time. So let me little bit talk about this thing. Temporal coding is very important. Okay. Now temporal coding, what are the cues for temporal coding is amplitude envelope and the fine temporal structure. So envelope, temporal envelope, okay, it has a fluctuations of 2 to 5 hertz. When we are stimulating, majorly, if PPS we keep around 100 or 250, that time this will be covered. Okay, and this help you in speech perception in presence of when the environment is quiet. But temporal fine structure, okay, it starts, the fluctuation starts from 100 hertz and it goes up to 1000 hertz also. So to get this encoded, we need a speech coding strategies with which can give very high stimulation rate, and this is the one which helps the perceive speech in presence of noise. It will help you in melody perception. It also helps in pitch recognition in a better way. When you are programming a child, these are the very important things which we have to consider. Number one, the stimulation level should be appropriate. Okay. Then you have to see that across all the electrode there is a loudness balance. If the loudness balance is not there, there will be very, the sound quality will not be good. And again, the most important over that is normal loudness perception. Normal loudness perception is if any softer sound is there, so we can perceive it as soft. If it is louder sound, we should perceive it as loudly. So that normal loudness perception is also very important. Because see, acoustically, this is the dynamic range which we have. So, it goes up to 100 dB. But when it comes to EDR, which is electrical dynamic range, the range is very small. This is when we convert that 100 second of acoustical into electrical dynamic range. It is only till 10 to 25 dB. So in the end, when we are doing programming, we have to see how much the system has a ability to compress the signal. Compression will help in balancing the loudness in the end. Okay, so if I start this, it will take a long time. So I'll stop here. I think some important things which I wanted to tell, which directly or indirectly help us to understand what is happening inside the cochlea, and which is important for speech perception things I was able to say. Yeah, thank you.
Can you hear me?
Yeah.
Thank you, Udit. That was a wonderful presentation. Technically loaded, I must say. And I hope the audience, especially the students, have taken a huge lesson from this, because this kind of amalgamation of stuff is not available in textbooks. So what you see here is a combined information from all companies, all technologies, everything available. The gist of his presentation, if I must say, would be what exactly is contributing to get those optimum outcomes from a cochlear implant, not to take away the importance of rehabilitation, of course. So I have two questions, one technical and one general. So the technical question that I have is, in your experience, because you've had the experience, a vast experience, what kind of a factor would give the patient, you say, a faster outcome?
So, see, we have seen various things, like we have seen the length, we have seen contact, impedance, this, that. But this is the balance which is exactly required. We have to see the anatomical perspective. We have to keep, it's not like once it is done. We have to keep checking at a regular interval what is happening. And then we have to keep these tactical checks under control, yes. Right? So, it keeps on changing with the time. Sometimes, there will be better outcomes, okay, with just default settings. But sometimes when you are improvising it, it keeps on, giving you better results. Yes. So, it is a heterogeneous population, and we have to, be behind we have to see what is happening behaviorally and what the software is telling you.
Yeah, because in general, there is this tendency to understand that, okay, I will set the mapping, appointments as per my protocol here, rather than I will set the mapping appointments based on the patient's mapping, like map levels being stabilized. So that thought process probably is something that you should reflect on.
Actually, these protocols, what we are seeing now, it is old, 10 decades old, right? So this is not what we should do nowadays. In government, they have to, because see, they have to give, money for the mappings and other thing, right? So they made it like after 1 month, and then 2 months, and 6 months. Actually, it is not done, okay? So just see whether it is required. When it is required, do as and when.
Yeah, it should be fluid. It shouldn't be like rigid.
The thing which goes in the tax is long back, because that time there was no experience with them as well, with the company. But now it's, go with the flow, basically.
So one last question, a general question. Why do you think that in spite of knowing that hearing loss, that is severe to profound sensory neural hearing loss, it can't be helped with hearing aids, why do you think there is still resistance in some group of audiologists to shift their patients towards cochlear implant? Why do you think? I mean, don't just say that it's monetary. It has to be something else.
You have seen it is technically, it is a very, very technical thing.
Yeah.
How we perceive it as hearing aid, poor, cochlear implant better. But why? To understand that, why you have to know this stuff.
Yes.
And I don't know that at what level it is being, told at the various institution level.
Yes.
Okay, some institution, yes, they are telling, they are, training well, but most of the institution do not.
Yeah.
And I can say that number is very high, which are not training adequately for these things. And obviously, then resistance will be there.
Yeah, and that's why we should congratulate Mrs. Sirisha and the team for organizing such a conference, wherein you're not just helping the students to learn, but also shedding light on what's available in terms of technological advances to help the hearing impaired population much, much better. Yeah, thank you so much.
I was just, want to suggest to the organizer, see if this would be a one topic, then, we would get more time, because this one slide is actually one hour.
Yeah, I could
Right.
see the...
So I was very fast, I know, I was very fast in, speaking, sorry for that, but the time was less.
Yeah, I would see the turmoil you were going through. I understand. Yeah, you have any. Thank you so much. Thank you, Dr. Udit.
Thank you very much, sir. Your depth of knowledge and research experience brought valuable clarity to complex issues in audiology, particularly in areas like auditory processing and cochlear implants. We truly appreciate the way you connected evidence-based research with practical clinical applications. On behalf of the organizing committee and all participants, we extend our sincere thanks for your time, expertise, and contribution to today's conference. As a token of appreciation, I would like to invite Mr. Harikishan Reddy and our chairpersons to kindly come forward and present a memento to our speaker, Dr. Udit Saxena. A warm round of applause, please. I would like to request Dr. Udit Saxena to hand over the momentum to chairpersons. Thank you very much, everyone, for your valuable contribution. Now I would like to invite Ms. Kirtana Hariharan, Senior Audiologist at Advanced Bionics, to give her presentation.
Hi, good afternoon everyone. Just a quick orientation. So I'm Kirtana Hariharan. I'm a senior radiologist in AB. I'm based in Chennai. I look after Tamil Nadu and Andhra Pradesh. So this is a supplement to what Dr. Udit has spoken. So he's entirely laid the foundation of cochlear implants. So this is going to be just an overview of what's new in cochlear implant with respect to advanced bionics. So if you look at a cochlear implant, there are two components, internal and an external. And there are a lot of innovations with respect to both of these components. Let me go with the internal implant first. So Ultra 3D is the latest implant that is available. And if you look at the story that's been there, at least 5 years ago, cochlear implant users were not able to get an MRI after they got a cochlear implant surgery because their internal cochlear implant wasn't MRI compatible or MRI safe. But these days we have an implant which is totally MRI safe and compatible. And what makes it so special is the multi-magnet assembly that you're seeing there. Every cochlear implant has a magnet. And this one is a special and a multi-magnet assembly where it has rotatable and self-alignable magnets. So what happens when your cochlear implant recipient with an Ultra 3D implant goes into an MRI room is this. So you have these magnets which can self-align. And when the MRI is on, the direction keeps changing. And the internal magnet self-aligns so that it is not causing any pain or discomfort to the cochlear implant recipient. So this is a truly MRI safe and MRI compatible implant. So that's with respect to implant. And if you look at the sound processor or speech processor, we, Advanced Phonics and Phonak are in a collaboration since 2009. We come under a common organization called Sonova. Most of you might be aware of Sonova. And because of this collaboration and synergy, we were able to put Phonak's 80 years of R&D into a cochlear implant processor. So then we designed something called Marvel. And for those of you who have worked with Phonak's hearing aids, Marvel may not be a new term. Marvel was a huge hit for Phonak's launches. And Marvel's technology is what is there in the latest processor that we have. It's called the Marvel CI processor. So how does it give powerful hearing? It is based on artificial intelligence. And these days we have deep neural networks and so on going. This is based on artificial intelligence, where the processor is able to analyze every half a second the environment, picking up even the slightest changes in the listening environment and applying adjustments or settings that needs for the listener. So what happens in real time is, imagine there is a kid with a cochlear implant sitting in a classroom and he or she is exposed to noise, right? So in that case, what happens is it's smartly recognizing that the kid is in a classroom and requires focus to the teacher from the front while reducing noise in the background. So this is just one example of one small thing that this Marvel CI algorithm can do. It's based on AutoSense. But I would love to talk about it more in later if someone is interested. So moving forward, so AB is like, again, with the partnership of Phonak, we were able to give something exclusive for your unilateral cochlear implants. Because if in India, if you see, 80% of the cochlear implant users are unilaterally implanted because of multiple reasons, and they lose out on the benefit of bilateral or binaural hearing. So what do we have is, any of your CI candidates can fall into these two major categories. They can either have no hearing on both ears or some hearing on any of the ear. So in that case, when they have no hearing on both ears, of course, the first recommendation as an audiologist would be to go for a bilateral cochlear implant. But in some cases, they are unable to do so. So what is there for them? We have something called a bimodal solution. All of you have learned, or we've dealt about bimodal. But what makes AB's bimodal solution better is we have an exclusive link hearing aid from Phonak that is specifically designed for a cochlear implant. And this hearing aid and a cochlear implant works together, is wirelessly linked. So signals from this side, from the hearing aid and from the cochlear implant are fused. So they get the true benefit of bimodal hearing. And if you look at the other major category of unilateral cochlear implant population, they are, so bimodal is available only for people who have residual hearing on the other ear. On the contrary, 80% of them don't have residual hearing on the non-implanted ear. And what is something that we can offer them is something called CROSS. CROSS, all of us know, it's a contralateral routing of signal. It's a simple tiny device that gets connected to the cochlear implant processor. And now suddenly the head shadow effect is reduced, my awareness to my environment is improved, and it's again not equivalent to bilateral hearing, but at least they get an awareness and 360 degrees surround perception that they have, which otherwise they would not have got with just the cochlear implant on one side. And this is something latest. People are on apps these days. We tend to use our phones more than what we think. So AB has a lot of apps, and now we are rebranding it into Advanced DigiCare. It's rebranded that. So in this DigiCare platform, you have access to a lot of rehab-related apps, and also something that can help your cochlear implant recipients. Just focusing on two of the latest editions. So imagine you could do a mapping at your clinic, and your patient need not be visiting your clinic, right? And most of you might be aware of the online hearing aid fitting platform that's there available with hearing aids. Not sure how many of you are practicing or using it regularly. But imagine for a person to get a mapping session, they have to travel all the way 200 or 500 kilometers, spend travel cost is there, effort is gone. And especially for people who are in the below poverty line, they lose one day or those wages when they take an off to get a mapping or travel to the mapping center. So imagine you could do a mapping. Your patient can be sitting in their home, work, school, literally anywhere and any part of the country, no restrictions. And another latest addition is where a cochlear implant user can monitor or measure their own listening efforts. So all these while, how you measure listening performance of your cochlear implant recipient is either aided audiogram, subjective tests, but now we have a whole lot of tests that are available. I can easily, I'll be able to help you out on understanding these. It's simply downloadable on your app, but because of time constraints, I'm just stopping at this. So these are the latest innovations with respect to implant, processor, and also beyond, what is beyond a cochlear implant technology. Thank you for the opportunity.
Thank you very much. If any of the participants would like to know more about this, can meet the ma'am outside. So with that, now I would like to invite Mr. Srinivas from ALPS here to present his presentation.
Yeah, good afternoon, everybody. We have a latest innovation in ALPS Nilo, which does not require any interface for doing the programming. It has only two apps, one client fitting app and one customer. So what the programming you do on the software, on the laptop or desktop, you can do the same on the mobile itself. Which for demo you can visit our stall number 6 in the down. Now you can go through the small video presentation on the Nilo. Sound.
On the golf course, it's the moments of careful precision and quiet concentration that carve the path to our most fulfilling achievements. Meet Nilo, the hearing aid where advanced technology meets elegant design, ensuring you never miss the whisper of the wind or the applause of success. Nilo embodies wireless freedom, rechargeable energy, and seamless Bluetooth connectivity, enhancing every sound life offers. With Nilo, experience life's beautiful symphonies, from the subtle rustling of leaves to your favorite tunes, streamed directly to you. Nilo, precision hearing, perfected for life's every moment. Immerse yourself in the clarity and connectivity designed for the discerning ear.
Thank you.
In life.
Thank you very much, sir. With that, we'll move forward with our next presentation.
As on the golf.
Our lunch break. It's now my pleasure to introduce our next speaker, Dr. Harini Vasudevan. She's an assistant professor in the Department of Audiology at Sri Ramachandra Faculty of Audiology and Speech Language Pathology, Chennai. She earned her PhD in audiology with a specialization in tinnitus from MISH Manipal and has an impressive background in diagnostic audiology, electrophysiology, and tinnitus management. She has contributed extensively to research, including international collaborations and multiple publications in high-impact journals. She is also an active member of the India Tinnitus Task Force and has been recognized for her teaching and clinical excellence. Today, she will be sharing her insights on the role of audiologists in tinnitus management. Please join me in warmly welcoming Dr. Harini Vasudevan. I now have the pleasure of inviting Mr. Ganji Srinivas and Mr. T. Narendra to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings. Over to you, ma'am.
Hello. Sorry. Am I audible? Yes. Yeah. I know you've been sitting for a very long time from morning. So before I start off my session, can you all please just stand up just for a minute? Yes. Just so that I know for the next 30 minutes you will not be sleeping. Okay? Just one small activity. Okay? I want all of you to close your eyes, and when I say right, you're going to turn right. Okay? Please close your eyes. Left. 90 degrees is enough. Left. Nobody is turning left. Yeah. Right. Right. Okay, fine. Yes. Thank you. Just wanted to activate all your, cognitive areas so that you pay attention to the talk. I thank the organizers for giving me an opportunity, and talking about tinnitus management, I felt it was something important that as audiologists we all should know. So I'm not going to say, talk about each of these contents, but there's a general perception that as audiologists we do a lot of assessment. We track the pitch, we do the loudness assessment, masking level, residual inhibition, and then what happens next? Most audiologists feel that there is only a limited option. Okay? So either if there's a conductive pathology, they send it to the ENT, get it resolved, or if there's a hearing loss, fit hearing aids. What happens with tinnitus? Audiologists actually play a very important role, and we are actually the center of the management because tinnitus is an auditory phenomenon. So our role comes from the very starting on identifying what is the cause for this tinnitus and then choosing what management, because there is no blanket treatment for every tinnitus patient. Give hearing aids for everyone, give sound therapy, give TRT for everyone. That doesn't work. We need to choose the appropriate management option for these people. And we need to educate these people on tinnitus. There's thousands of websites and online information about tinnitus and how to cure it. It is our duty as audiologists to give the right education to the patient on what are the myths about tinnitus and how do we treat or how do we move forward. And then we have to manage tinnitus either by giving a direct or an indirect. Now I understand there are some conditions where we cannot treat it. If it's a vascular cause, it is not on the purview of an audiologist. So there we play an indirect role. But there are most of the subjective tinnitus cases, we as audiologists play a direct role. And at last, once giving a treatment is not enough. The tinnitus might suppress, but in case it comes back, what should the patient do in case of a relapse? That is very important. So I feel that the first thing that you go and search online about tinnitus, you go and type management of tinnitus. These are the list of options that you're going to get. So many options for tinnitus. Where do I start? So I will always say the first step in tinnitus management is counseling your patient. And counseling, I don't mean ignore the tinnitus. It will go off on its own. Don't think it's a big issue. This is not the counseling. There are different styles of counseling. One is an auditory rehabilitation counseling. That is, if the patient has a hearing loss and a tinnitus, the way I counsel is different. Or if it's something just for a motivation, that is, a patient with tinnitus has a lot of anxiety, depression because of it, I need to target that. So my counseling should change accordingly. Now the different types of counseling methods are available in the textbook of tinnitus. I don't want to go into detail of each, but one thing that I will talk about is a psychoeducational counseling. So here we talk about the anatomy and physiology. And this is, I'm not talking about, cochlear nucleus, medial geniculate body, all these things the patient does not need. But a general anatomy on where your ear is, how do you hear? This is very essential for the patient. And how do we perceive the sound? And what are the results of the test? You've done a PTA, you've done an emittance, you've done a BERA, any testing that you've done. What is the result? What it means actually? The person coming with tinnitus does 10 different tests, okay? But what is the meaning of all these tests? It is our duty to explain these test results to the patient, and then I need to talk about how to get habituated, how to get used to the tinnitus. Keep listening to it, you will get used to it. That is not habituation. There are some techniques that we need to tell them on how to get habituated to the tinnitus, and also how to divert their attention. If somebody comes and tells you, ignore the projector, the first thing you're going to do is look at the projector. So when you say ignore the tinnitus, it's very difficult for the patient to ignore the tinnitus. So we need to tell them what to pay attention on rather than the tinnitus. That is very important. And what are the different self-management strategies? And if it, in case comes back, the relapse. So we always need to ask the patient to look for a SMART goal setting. That is, I can't say you come for 3 sessions of TRT, do for 1 month, your tinnitus will go off. This is not how I set a goal. I ask the patient in this room how annoying your tinnitus is. He says it is 9 out of 10. 70% it's affecting me. I will say that slowly from 70 we'll get it to 60. To 50. So this is a specific and a measurable goal, and I know I can achieve it. I can't keep impossible goals. If the patient with severe tinnitus comes and says, from tomorrow I don't want to hear this tinnitus, that is not going to happen. And that's going to cause a disappointment from the patient's side. So we need to set a realistic target and make them understand. And also sleep hygiene techniques. Most patients with tinnitus also have difficulty sleeping at night. So we need to advise some sleep strategies, okay? And what are the daytime habits that can improve sleep, and some relaxation techniques. Attention control techniques I'll be talking in a moment. And in case they have a hearing loss, you need to talk about the various communication tips that can improve their communication, okay? So this is what I mean when you have to tell how do we hear. So when we hear normally, there is a sound. You first perceive, you encode it at the cochlear level, and then at the brain level, you understand what it is, and then you perceive it. But for a tinnitus, there is no external sound. But how do we perceive it? Okay, instead of telling a patient, tinnitus is a sound that has no external auditory, sound source, patient does not understand that. But when you say that there is no external sound, but you still hear it, so what is happening in between? So that is what we need to explain the patient. This is something that I always tell all my patients is for shifting your attention. So what do you look at here? You have 2 faces. But when I tell you to focus on the white area, you can see a flower vase. So this is how you shift your attention. I know depending on what I see and what I shift my attention, my perception will also change. So instead of the tinnitus, I want the patient to target or listen to something else. So this is something you can use for attention shifting. This is for a figure ground perception. And most of the time we know that hearing loss, when there is a sensory deprivation, the brain, there is a central mechanism, tinnitus automatically comes. As an audiologist, you understand this statement. A patient does not. So I'm going to tell that these black dots that you see are the absent activity, and the white dots are the normal activity. So now, if you can see in the interjection, okay, of the black and white dots, you can see some gray color dots appearing, okay? So this is what is called the phantom perception. Your brain does not like incomplete information. It likes to complete. It needs a closure. So what it does, it fills in the gaps. I have a hearing ability, some frequencies, high frequency, I have a loss. The brain does not want this gap, so it tries to fill in that gap. So tinnitus is one of the mechanism where it is filling in. So like this, if we can explain to the patient, they can understand better. Instead of saying you have a hearing loss, that's why you have a tinnitus. So next, if you ask, so for all the patients, do we counsel? We are not psychologists, we are not trained, okay? So what are we going to do? So let's look at patient here A. So he has a hearing loss, but a low psychological impact. So here, I'm going to just give him counseling, not much about tinnitus because it's not going to irritate him so much, but for the hearing management, I am going to give him hearing aids or any other audiological management. If you feel that the patient is having a lot of psychological problem, we definitely need to refer them to a psychologist, because if we know that the patient is depressed because of it, we cannot handle, we need to work as a multidisciplinary team. Okay? So the first step of tinnitus management is counseling, explain to the patient, and then what are all the management. So I like to classify the management options into two classifications, that is bottom up and top down. So bottom up, I consider that whatever I can repair from the cochlear side of it, I will aid. I'll give hearing aids, I'll give cochlear implants, etc. Top down is if the patient has a profound hearing loss. How to give sound therapy. The sound does not reach the cochlea at all. But the tinnitus is ultimately perceived at the brain level. So what I do, I am going to stimulate the cortical level and see if there is a reduction in the tinnitus. So with respect to hearing aids, if the patient is having a hearing loss accompanied with the tinnitus, definitely hearing aids are an option. We need to activate tinnitus features. It is going to act as a masking device. And how will it be helpful is, it promotes, the sensory deprivation, you're going to overcome that. It's going to improve his communication skills, and it also provides masking. And there is a literature support that you can use, and it is effective. With respect to cochlear implant, there are systematic reviews that have told that cochlear implant is a feasible option for individuals who are a candidate of CI, that is with severe to profound hearing loss. But we also need to be mindful that sometimes if the patient is having a residual hearing, and if that is getting depleted, new tinnitus can be formed or tinnitus can increase. These are some things that have been reported in literature. The third one is sound therapy, most common methods that's been used from ages. What it does, sound therapy, you're going to promote reorganization in your cortex by eliminating the tinnitus. There is a mixed evidence when it comes to sound therapy, but there are a lot of sound generators out there. Even in Amazon, if you go, there are a lot of sound generators that you can find, either individual sound generators or pillow speakers or personal headphones are being given for listening to these sounds and to promote a cortical activity. This is something that I've been working on for some time now, that is residual inhibition therapy. So here we give auditory stimulation that results in a temporary suppression of tinnitus. Again, I'm saying it is only temporary, but there is improvement of around 90%. So what happens is, when I'm going to give this white noise and I'm going to suppress the tinnitus at the cochlear level, many things can happen. One is masking. The second thing is actually the patient starts to believe that something can be done for the tinnitus. It does reduce when I'm going to give an external noise. So this is one evidence from a case series that we have published. Hello? Hello? Yeah. Am I audible now? Yeah. So we had 10 patients with tinnitus. What we did was we gave them psychoeducational counseling for 30 minutes, and then we gave them residual inhibition therapy, and we recorded P300 pre and post. And with a single session, we could see a huge improvement in the cortical auditory evoke potentials. And hello? Yeah. And to add on to this, you're able to hear? Okay. Okay. So, instead of just giving counseling and residual inhibition therapy, I know residual inhibition therapy is temporary. The patient can get a tinnitus back. That is, it can rebound. So, what we did was we clubbed it with a sound therapy for 1 month, and we saw how is the effect, and we used THI, ICF TINI to see the difference pre and post. We're still monitoring these patients, and there is a statistically significant difference in the tinnitus pre and post. Next is your TRT. This is something that everyone has been, taught in your class. That is the Jastropov's model. That is, every sound you hear, you classify that sound as a positive, negative, or a neutral sound. And most of the time, tinnitus has been categorized as a negative sound. So this tinnitus retraining therapy, I'm going to make this negative sound to at least a more neutral sound. That is, I'm going to help the patient to get habituated so that he does not get annoyed with this tinnitus. So retraining counseling is to reclassify the tinnitus, and the sound therapy is to decrease the contrast between the tinnitus and the neuronal activity. So my goal of TRT is going to get habituation of the emotional reaction, the response to the tinnitus, and the tinnitus perception. One thing we should understand is TRT directly does not influence the tinnitus loudness, okay? It indirectly influences the tinnitus loudness. There are a lot of randomized control trials on the effect of on TRT. And this is one of the study, recent literature, where they had two groups, one group with TRT and the other group with standard care. Both of them wore hearing aids, but the TRT group had somewhat effectiveness in tinnitus compared to the other groups, okay? And there was another meta-analysis that was done recently. This was predominantly in China. So here also they said that TRT is effective. However, there is a lot of bias in the current studies, and they need multi-centric studies to prove the effect of TRT. So masking therapies, these are just plain giving, external noise for them, the patient, so that they get distracted. It's effective, it's non-invasive. So these are the possible methods that you can give from the bottom-up approach. Either give hearing aids, cochlear implants, give residual inhibition therapy, sound therapy, masking therapy, everything. Now next comes the top down, that is, you're going to stimulate at the cortical level. So where I'm going to present current through either implanted or surface electrodes to achieve functional activation. So I know that there is auditory deprivation, the neurons are not acting enough, so I can either increase this activity, or if they say that there is tinnitus is caused due to hyperactive neurons, I can decrease this activity in some areas through neuronal stimulation. So TDCS is something, even in yesterday's talk, a lot of our presenters were speaking about TDCS, that is transcranial direct current stimulation. So it's a popular method to modulate the cortical excitability. There's a lot of systematic reviews and meta-analysis that says that there is a small to moderate effect size. That is, not every participant has gotten an improvement, but approximately 40 to 50% of the participants in most studies have gotten an improvement. So we tried out doing TDCS on one subject who had profound hearing loss. So we used a Sotrix transcranial DC stimulator equipment, and we placed the anode electrode midway between C3, T5 and the cathode between T4 and F8. This is the international classification for 1020 system for electrode placement. And we gave 1 milliampere current for 20 minutes, okay? So the first phase, what we saw was we gave for 5 days, and then the person had a THI score of 92, then it kept reducing, but after a week it came back. So what we did was from 5 sessions, we increased it to 10 sessions, and if you can see the scores there, so from a starting of THI and TFI score of 66, the final result was 4. Okay, so this is only one case study that we have tried out, and we thought it works, but however, we need to have more literature support to start this off as clinical. There are systematic reviews and meta-analysis that says the efficacy of TDCS. So when you're giving current stimulation, the place where you give, that is very important. So most of the studies, they either take 2 places, okay, dorsolateral prefrontal cortex or the temporoparietal areas. So this systematic review compared these 2 areas, and they found that the left temporoparietal areas, when it is getting stimulated, there was more effect compared to the frontal areas. So that is one type of neurostimulation. The second type is transcranial magnetic stimulation. So that is, you have a magnetic coil that you place near the patient's brain, and when there is a current that is flown between this, magnetic field is getting generated, and this magnetic field can alter the neuronal excitation, whether the neurons can, improve the firing rate or decrease it. There is an effect on RTMS. However, there are some complications of RTMS. There are lots of patients who report headache, sometimes tinnitus worsening, sleep disturbances, stiffness, and some painful sensation. So these are reported. So it is still at a research level, not at a clinical level. Next is cognitive behavioral therapy. So here what we are doing is we are trying to restructure how the patient perceives the tinnitus. Okay, so by changing their behavior or reaction to their tinnitus, how we can improve. So CBT mainly stresses on mindfulness and relaxation, and it does not improve the acoustic characteristics. You do CBT, tinnitus loudness will decrease. That's not what is it. CBT has an impact on the psychological characteristics more than the acoustic characteristics. There are a lot of trainings that are available for CBT. Not everyone as audiologists can give CBT. You need to get trained, and there are some organizations training audiologists also for cognitive behavioral therapy. And let's come to this. This is very important. Everyone, they want something in their mobile phone, an audiologist can prescribe. So there's so many apps that are available for tinnitus. So there was a review that found more than 300 apps just for tinnitus. So what does literature say is there is an effect, okay, on using these smartphones for sound therapy or for masking therapy or for relaxation. So there are a lot of systematic reviews. These are some of the apps I found in the American Tinnitus Association website. This is purely for sound therapies, and these are the apps that you can use for sleep and relaxation. So these are the current managements that are, happening in the field of tinnitus, and as audiologists, it's aware that, we should be aware of all of this so that we get trained and we start helping out our patients instead of saying ignore your tinnitus. There are a lot of studies on the future directions on giving lingual stimulation, bimodal stimulation, promontory stimulation, but the effect using RCTs, it still needs to be done a lot, so I have not presented it here. So my take-home message to all of you is, audiologists, we play a very important role in the management of tinnitus, and the initial or the first step is to educate the patient. Explain them what tinnitus is. It is just a symptom. It is not a condition on its own. And we need to assess the condition properly so that we can see what type of management is applicable for them, whether it's a bottom-up approach or a top-down approach. And there's no single treatment, there's no single umbrella that I can say that you use masking therapy for everyone with tinnitus, it will work. It is a game of trial and error. And if we can use an eclectic approach, that is a combination of approaches. Not only educate, I give a therapy, I also tell them how to monitor it at home, that can be a little effective. It cannot be cured. So I'm not asking you people to tell your patients that I will cure your tinnitus, but as audiologists, we should be able to manage the tinnitus effectively. And we should be confident about that so that our patients start believing in us and we can start with the management. So are there any questions? Yes, sir.
Hello.
I have a couple of
Hello.
questions.
Yeah, it's working. Yeah. Any questions?
Yeah, I'm here.
Yeah.
I have a couple of questions. Number one was related to the tinnitus inhibition, so residual inhibition. So, in your experience, have you seen? Is that fine? Yeah. In your experience, have you seen anybody in whom the tinnitus inhibition has been permanent?
Hello, yeah. Sir, when I if it's more of a psychological game, sir. So when I make the patient believe that your tinnitus, that is residual inhibition therapy, works for most people, it's how they take it. So for some people, they feel it is permanent. My tinnitus is gone completely. But once they go home, it might come back. The suppression duration can vary, but I will not suggest it as a permanent solution. So what we do is, after the residual inhibition therapy, we club it with a sound therapy. We always suggest two things, that is environment modification and sound enrichment. So when they are in a sound enriched environment, they don't hear, they don't actively pay attention to the tinnitus, so they feel that the tinnitus is gone. So that's how it works, but directly suppression, I don't think it works as a permanent solution. If at all there are some reports, even in my study, I most often attribute it to the psychological component, that they feel that, you know, I have treated their tinnitus and they're very happy with it.
And the next question is related to your last point. When you tell a patient that I cannot cure your problem, but I can help you live with it without it affecting you, I mean, I'm just relating it to my area of work. I work with vestibular disorders, and people like those who are suffering from Meniere's disease or vestibular migraine, we say something similar to them, and then we realize the facial expression completely changes. Now they no longer believe in whatever we are saying.
Yes, sir. We also face the same thing, but the key is in the way you say it. I usually say that I can't give you one tablet, or I'm not a doctor that will give you just one treatment and you have it for 10 days, your tinnitus is going to go off. But I can help you to reduce it from 70 to 60, and slowly in the process, if you are able to trust the process, we will see a difference. I usually give an example. That is, if you are going to any weight loss training program or something, in one day you can't reduce 20 kgs. So they can't give you that. So it depends on a lot of factors. So I say them, you have patience and we will help you to manage it effectively so that it does not affect your day-to-day living and your work and your sleep. So all those, if I'm able to manage, the patient gets some confidence, and the key is in how we deliver the point to the patient. But it is a difficult thing when we tell them there is no cure. The moment we say it, their face changes. So we have to lightly sugarcoat it and tell the patient. Yes, sir.
Thank you, Harini. I think that was a great presentation and very, very clear.
Yes, thank you very much, sir. Yes.
Harini, very good presentation. I really appreciate the effort that you have put in doing all this. My question is, most of the hearing aids now have tinnitus maskers and all, which are working with them is what they say. So what do you think? How effective is it?
Hearing aids.
Hearing aids with maskers.
The first thing is, hearing aids, when I'm going to prescribe, the moment they see the rate of the hearing aid that has a tinnitus masker, it is a big no for them. So how much ever I'm going to convince the patient, they're saying that I am paying 25,000, 30,000 for this. My tinnitus is still there. What are you doing? That is the first question that they're going to ask. So we should make them understand this is only for masking, not for suppressing. So when we are able to club it with another treatment, hearing aids definitely work. As in on its own, just giving hearing aids for tinnitus, I don't
not going to help.
recommend.
Yes. Thank you. Thank you so much.
Yes, ma'am.
Surgery, if you have, then they say I have developed tinnitus.
Yes, sir.
Okay, so for them, do you suggest anything?
So most of the time when you're going to deplete the residual hearing, tinnitus is going to come. Because anytime there is going to be a damage to the inner hair cells or anything, tinnitus is an immediate response. So after, when it comes, we need to suppress it either through, giving stimulation, or we have to try other methods on, cognitive behavioral therapy on how to reduce the impact of this tinnitus on their life. But the loudness of the tinnitus, we cannot guarantee. That is the acoustic character. I will reduce your tinnitus from 70 decibel to 50 decibel. I cannot say that. But the impact of the tinnitus, I definitely can reduce it. So that way we can help the patient after CI. But it is one annoying thing that after a surgery, you develop tinnitus. It's something that is very...
No, generally we say the tinnitus can be suppressed after surgery. Okay, after surgery, many of them, even I have got little experience in cochlear implant. So, see, what we say is if the tinnitus with profound hearing loss in both ears is an ideal candidate for implant, we say generally. because the tinnitus can be suppressed. Okay, but few of them really literally developed, a few doctors. Okay, they come with sudden hearing loss and they get it done. I have developed tinnitus, and what they say is, because generally everyone Google it and they can search. So based on that, what they say is it is physiologically I'm hearing. Okay, so and what everyone is saying is psychologically you treat, because even I know how brain works, and for those people it is really difficult to treat. And even whatever, as you said, okay, we reduce the gain or whatever, okay, dynamic range, whatever, the shift and tilt, whatever you say. But the thing is, ultimate what they say is, little it is reduced, but it is dominating my hearing, they say.
So for individuals with profound hearing loss who get tinnitus, I usually feel TDCS, that is cortical level stimulation, works, sir, because there is nothing that we can do from the external side, giving any amount of noise or something. There is no cochlear hair cells to respond and receive it. So if we can target the cortical level, there is a huge difference. But studies post CI giving TDCS are still there. It's upcoming, but the effectiveness is only 40%. They've not gotten a huge success.
Exactly.
Still looking at other options for these individuals.
Yes, yeah. Yes. Right. So any more questions?
Madam, it was a very excellent presentation.
Thank you, sir.
So just being a psychologist, I just wanted to know, you said most of the cases could be psychological. Acoustic also be there, though. But do you have any studies stating that this many percentage of tinnitus comes under psychological?
So tinnitus is a symptom of a condition. Okay. So when they get it, obviously half the people, if it is distressing me, it is impacting my life, there will be some kind of anxiety or depression. And there are a lot of studies that have quoted that individuals with tinnitus, that is 50 to 60% of them, do face some of the issues, and there are some extreme cases where they are suicidal also. So when we see all these points, we immediately refer them to a psychologist, because that is not an area that we can counsel. I can only counsel from an auditory perspective that this is not something that you hear a tinnitus, after some time I'm going to go deaf. Everything, I have a tumor in my head. I mean, even though some tumors, the first sign is tinnitus, but the fear makes them do a lot of crazy things. So we have to bust those myths about tinnitus and educate them. And if it is in our purview, we will see it. And if it is crossing a boundary, we usually have a checklist. We usually refer them to a psychologist so that they can also be a part of the management.
So you said we can refer to the psychologist or psychiatrist. So psychiatrist generally gives tablet, medicine gives, or counseling he will be giving. But general psychologist may not be knowing tinnitus, what is tinnitus or the symptoms of tinnitus. It's you as an audiologist, you have to make the people understand. And then, so because most of the audiologists or speech pathologists also do counseling part. So in the case of psychologist, so how he has to react and how depth of knowledge he has about the tinnitus.
Yeah. So that's why not to every psychologist I will refer. We will have a team wherein I know that I can refer to this
At Oticon, recent insights have taught us that it's not enough to be an expert on sound. Rather, we must understand what users want to listen to and how they behave when they communicate. Whether the sound scene is incredible.
Thank you, Dr. Harini,
yes,
for a wonderful presentation.
Thank you.
Really,
thank you.
You have, your insights of tinnitus are really good, and you have given very good overview.
Thank you. Thank you very much,
and the treatment and audiological point of view, how to treat and everything, even cochlear implants and hearing aids, how it helps. Really good presentation. Thank you.
Thank you. Thank you very much, sir. Thank you for providing me with this opportunity. Yes.
Thank you, Dr. Harini Vasudevan, for your insightful and comprehensive presentation on the role of audiologist in tinnitus management. Your expertise and dedication to advancing tinnitus care and research have provided us with valuable knowledge and practical approaches. We truly appreciate your time and contribution to the conference, ma'am. Now I would like to invite Mrs. Lavanya to give us a token of appreciation to ma'am. I would like to request the chairpersons to join. She has given us presentation. Can I expect claps for her? I would like to request Dr. Harini Vasudevan to hand over the momentums to chairpersons for chairing the sessions. Thank you everyone for your contribution. Now let's move forward with the company presentations again. Now I would like to invite Mr. Kalyan, audiologist from Pune company, to give his presentation.
Check. Yeah, okay. Hi, very good afternoon. Hello, I'm Kalyan. I'm an audiologist. I work for Sonova. Not able to hear this? Okay. Okay. Is this clear now? Okay. So I work for Sonova. Now Sonova, if I want to just introduce you what Sonova is, I think Keertana spoke about it. It's like Phonak, Unitron, Hanseton, and Advanced Bionics, and we do have some retail outlets too across the globe. Not in India, but today I'm going to update you a few things which is new about, we came up with a new technology. It's called Infinio, and most of them are aware of that. There are something called AI-powered hearing aids, brain hearing aids, deep neural network, machine learning, complex algorithms. So we can't take a class about it, but you can go and search it on Google, get a lot of articles to read it out. Before I forget, I wanted to remind myself and everyone, like from a recent speaker, the last speaker, like Dr. Harini, which you spoke, I love that word, psycho-educational counseling. I think most of our audiologists, we don't educate our end user. In speech therapy, or in a hearing aids management or anything it is. So educating an end user or educating a client or the patient, it's a key important role. I think this actually I take this, madam. I love that word, like psycho-educational counseling. Thank you. Coming to this, so this is a portfolio. Sorry. Yep. So we have introduced into our RICs. There are two models. One is Infinio rechargeable and one is Infinio rechargeable Sphere. So something special about Sphere, and there are few things which are like, they were both curious about how durable these hearing aids are. Now let's say any individual or a hearing healthcare provider will able to pick up a hearing aid looking about sound quality, reliability and durability. So all the hearing aid brands, they develop a great technology, and they do also provide features which can maximize the benefit to our end user. Same way, I'll try to highlight the reliability and durability about these technology, how Phonak or Sonova is developed these things. So we do wear hearing aids for 12 to 15 hours sometimes, and there are people who use it for 6 hours and 8 hours. So we always say, our hearing aid come for a repair, or the hearing aids are not being used in a great way. So it completely depends upon a person, how is he handling a device. But how roughly you use it? It should be a important device where we use it for 15 hours in a day. It's a part of our lifestyle. So your device should be more reliable. So Infinio, all the devices are completely a waterproof technology. So there is something, they have it for regardless of water, dust, etc. So there are a few validations which they have done. I'll just go a bit quickly. Yes. So this is something we generally see paralleling coating in most of the electrical devices, but they were not introduced into hearing aids much. So we always say that you have to put your hearing aid to dry kits, and you have to use them very carefully to make it more longer life. But right now the hearing aids are with rechargeable. They are integrated with a lithium-ion battery. So these batteries, these hearing aids get interfere with a lot of other environmental factors. Let's say if this hearing aid is a waterproof technology hearing aids, if I drop into the water, I can just drop into the water, and what happens with the hearing aid? Your hearing aid doesn't work. But still these hearing aids can withstand for a duration of time to overcome the resistance towards the water. Example, there is something called paralleling coating which will not make your hearing aid condense. Condensation is a big one which affects the electronic gadgets. So paralleling coating is something which will protect them for condensation happening inside the hybrid, and also the chemical reactions or the discharge happening at the hybrid level. So it will try to protect the hearing aid in a better way. And then next there are something called Teflon coating, hydrophobic coating, Gore-Tex lining, silicone seamers. All this we use it in most of the waterproofing ceilings and all this stuff. But right now we have it in our hearing aids also. So these hearing aids, you can swim with these hearing aids, you can shower with these hearing aids. You can also use them for water games. In fact, generally if I want to use it as a tip, I recommend these hearing aids to a person who's having memory issues. Like they forget they're wearing a hearing aids, they go, they shower, they take a shower, they do a face wash and all those stuff, and they get anxious. And there are people who are sweat a lot. Generally, sweating will accumulate a lot of dust and also affects when you're not de-drying your hearing aids properly. So your hearing aid might get affected or fail to work within short duration of time. So these waterproofing technology for these hearing aids are something great which they came up with Infinio. So as of now they are with on RACs. So we are coming up with BTs too, and also rechargeable ITs also. I'll just show you some pictures how this plasma coating and hydrophobic coatings have been injected. This is something. This is called paralleling coating, how will they do it on the hybrid. So the technology is so leap forward, they can make this coating on a smaller hybrid to protect themselves for a longer duration of time. And this is something called capsulated battery. Generally, most of the batteries, when we have integrated with the hybrid, when they are exposed to environmental factors, like putting in a balcony or nearby a window, your battery might get affected. But with this capsulated technology, like covering a battery when deoxidized and put your lithium-ion inside it, it has a less chance test exposed. Like with this, these hearing aids are quite popular in using in a rough way. So these are the hearing aids which are highly durable, which are available in the industry. Yeah. So this is something like we all know we use AI-based algorithm in hearing aids. It's been there since from 15 years. So it's complex algorithm what we use in our hearing aids to make a feature work in a real time. Generally, if your hearing aid is having a bigger latency and bigger delay, then it might affect your coordination and it might affect overall intelligibility. So now why this technology has come up is there is a demand from the end users. They ask us like, Kalyan, I want to perform in a loud noise. Kalyan, I want to perform in a party area. So we have some limitations with the hearing aids. Of course, with any device, we do have some limitations. But within the limitations, how can you serve best with the technologies? This is something beyond in hearing aids which they have introduced. They have developed a separate chip called deep sonic chip. It's called a spearic speech clarity in loud noise. So this deep sonic chip has been trained in such a way to generalize task-oriented, it's completely a deep learning where how you perceive a sound from different directions and you recognize where the speaker is from. Same way this hearing aid will help you to restore or approximate to make you listen the speaker around you. I'll just skip this. So now we can say like, Kalyan, how did you develop this one? But I can just show you what had happened actually. So there are a lot of articles out. You can just go and have a look into it. So this one, it's almost, generally they do train these hybrids with a greater sample of size. Generally what they do is they procure the different sound samples from different places and they'll try to train this chip. And to be most faster to differentiate speech and noise, it will has a great speed power that is almost 53x more powerful than what are the chip we are using right now in the industry. Say, for an example, a hearing aid can try to take a sample and process the signal or the sample size, like signal or the noise. But here in this spear, it will try to separate the signal and noise. And it will try to do a task-oriented thing in a real time so that a person who's wearing this hearing aid or using this hearing aid in loud noise conversations, he will not miss the speech sounds when in spite of a lot of multitaskers around him. Other thing is like they use the approximation. There's been inspired by 4.5 million neural networks. How our brain network keeps moving and keeps processing. Such a speed this being developed. And the fast of the speed is 7.7 billion seconds operations per second, which is like quite faster. It's like real time generally. So with this, we can achieve better speech clarity in loud noises around, from all the directions. So there are two chips. Generally, a hearing aid has an integrated hybrid, but in Spear, we have two chips placed in it. Yep, I think I'm done, but there is something which I wanted to show you before. Yes. So this is something a lot of our audiologists, they don't admit that we have assistive listening devices because there are a lot of limitations with the implant process and hearing aids. So apart from that, if you want to extend your listening needs, you should have an external mic. So there are types of mics. In that, I want to talk about Roger. Roger is something, an advanced FM. The dynamic range is up to 80 feet. It's in a big theater hall. You can use that with a speaker. Like how I'm putting this mic in front of me. Same way, I can just hold up this mic, or I can show it like this, or I can clip it. There are a lot of modes, and this will help most of the people to achieve a better signal-to-noise ratio. You can expect a 25 dB of signal-to-noise ratio, and that depends how much amount of noise you are presenting in. There are validative studies which we did for 70-75 noise, where we do a validation. But this is beyond something like you use a Roger. It's practically I did it in a party to use a Roger. I perform better than a normal person. So it is a study which is placed. A person with a severe hearing loss using with a Roger is 10 times better than a normal person in a noisy environment. So the impact is so great. I recommend every audiologist to talk about these things, especially for the kids and people who are having a poor signal-to-noise ratio where they can't achieve a better speech processing, or else a person having auditory neuropathy or speech processing disorders. This will help them in auditory rehabilitation to restore their speech cortex in a better way. Thank you so much. There are a lot of things to talk about, but you can come down to my stall so I can provide you a few information on this. Thank you. Thanks a lot.
Thank you very much. If any of the participants would like to talk to them about any of the hearing aids and further technology, please meet them in the stalls out there. Now, I would like to invite Mr. Ranjit from Audiocon to give his presentation. Thank you.
thanks from OTCon for giving opportunity to participate in this conference. And myself, Raju, and my colleague Ranjit. So we are from OTCon, and you know all about brain hearing technology. So this year, taking the brain hearing technology to the next level, we have introduced Intent. So Intent 1 and 2 series are introduced. So I know everyone are hungry to go to lunch, so just we'll go to the video, which covering all features of Intent. Let's go to the video.
At Oticon, recent insights have taught us that it's not enough to be an expert on sound. Rather, we must understand what users want to listen to and how they behave when they communicate, whether the sound scene is incredibly complex or even very simple. That's why we have introduced Oticon Intent with 4D sensor technology. Our mission was to find out how this new technology helps people in conversations and ultimately in life. Partnering with the Technical University of Denmark, we designed a deeply immersive virtual sound experience in a 64-channel spherical loudspeaker array in the Audio-Visual Immersion Lab. Here, the test participants had real-world tasks to solve. The test participant had to find the person talking about a certain topic among 4 speakers, telling different stories in background noise by moving their head and their body. Then we tested their comprehension of the story. But what is the effect of intent-based processing on the brain? Participants in a parallel study listened to news clips while real-life surrounding sounds were presented. By recording EEG, we analysed how speech and surrounding sounds were balanced in the brain. Finally, our researchers conducted a wealth of technical measurements over the course of many months. And the results were remarkable. Technical measurements showed that even with a single, complex listening environment, Oticon Intent continually adapts its hearing support in a range spanning 5 dB output SNR, depending entirely on user behavior and intention. And when compared to our best previous hearing aid, Oticon Intent gives an incredible 35% more access to speech cues. Our immersive VR study revealed that the new 4D sensor technology is responsible for a 15% improvement in speech comprehension while preserving access to speech all around the user. And we could see the effect on the brain when EEG results revealed that attention to surrounding sounds is significantly higher when a person is actively navigating a room compared to when they're part of an intimate conversation, just as we would want it to be. All while the brain's attention to speech remains constant and stable, no matter what. Finally, compared to our best previous hearing aid, Oticon Intent is rated by users as having 10% better sound quality, 13% more nuances in the sound scene, and 10% higher listening comfort. By continuously adapting support even within a single difficult environment as the user's listening intentions inevitably change, Oticon Intent helps people engage in conversations and in life like never before. Oticon, life-changing technology.
డ్రైవ్ యాక్సెస్ లేదండి నా ల్యాప్టాప్. వాట్సాప్లో షేర్ చేశాను పీడిఎఫ్ ఫైల్ జస్ట్ కంట్రోల్ చేసి. Yeah, pen drive. Regulatory affairs, data sensitive. All right, all right. Then share చేశాను. Full screen. Control L. లేకపోతే ముందులాగా పెట్టేసి స్లైడ్స్ చేంజ్ చేసి. Good afternoon, everyone. I represent Tavis Life Sciences. We specialize in ENT and audiology equipment. Let me quickly walk you through our product range. Next. Presenting you Audicom. It's a hearing aid comparative system. You can quickly compare like 3 pairs of hearing aids simultaneously, and also you can give the experience to the patient's caregiver. Next, we have a portable PC-based diagnostic audiometer called Oscilla. It comes with supraoral headphones and has an advanced headset with 30 dB noise reduction. And this also has a PC plug-and-play software. And then for vestibular range of products, we are associated with Dr. Srinivas Dorsala's company called Equidor Meditech. Our vestibular portfolio includes computerized postrography device, video nystagmography device. This is an advanced VNG which comes with eye tracking and head tracking. And then we have functional head impulse test and an advanced CCG. For sleep apnea, we have iNap. It is an intraoral negative airway pressure device. This is an alternate to patients who cannot tolerate CPAP. Next, we have wireless endo camera. With this, we can wire through Wi-Fi. You can stream it with any wireless device. Yeah. Thank you for your time.
Thank you very much. And we have come to the last company presentation for the day. And now I would like to invite Mr. Praveen from Videx Evanthos India Private Limited to give his presentation. we are sorry for the technical glitches. We are not able to do it further. So we'll be doing it in the afternoon session after the lunch break. So yes, we got to know that many of the participants have not signed in the RCI forms. Please do sign before you go for the lunch. So yes, we can leave for lunch now. A delicious meal have been arranged for all.
బ్రో ఒకసారి ఎల్ఈడి వాళ్ళ బ్యాక్ సైడ్ వెయిట్ చేయండి ఒకసారి వీడియో షాట్ అయిపోయిందో తీసుకున్నా వాల్ ఆఫ్ చేయాలి ఒకసారి శుభాని ఒకసారి ఇలా చూడండి అందరూ బ్రో వాల్ ఇచ్చారు one more wait. I'll go stay there. నేను సేవ్ చేస్తాను
వెయిట్ మేడం ఇచ్చింది చెప్పు పర్వాలేదు ఇబ్బంది ఏం లేదు ఇప్పుడు ఏం బాగా
And improve, all without anyone noticing a thing?
Hello everyone, welcome back. I hope you all had a refreshing lunch break. On behalf of the organization, I warmly welcome you back as we resume the next segment of our program. We have an exciting lineup of sessions and speakers ahead, so we encourage you to settle in and stay engaged as we continue this meaningful and enriching event. Let's move forward with renowned energy. So we'll be starting ahead with first talk of Dr. Vijay Kumar Nane, sirs. Yeah, it is with great pleasure that I now invite Dr. Vijay Kumar Nane, a distinguished professor from the Department of Medical Rehabilitation Sciences at King Khaled University, Saudi Arabia, to address us. Dr. Nane brings over 15 years of rich experience in clinical audiology, research, and academia. He has diverse and impressive career background that includes positions in India, Australia, the UAE, and now Saudi Arabia. His extensive work in auditory sciences encompasses teaching both undergraduate and postgraduate students, conducting pioneering research, and developing innovative diagnostic tools and protocols. He has published more than 40 papers in reputed national and international journals, and his contributions to the field of audiology have been widely recognized. Among his achievements are awards for best paper presentations at international conferences and the development of novel screening and speech enhancement techniques. Today, he will enlighten us with his expertise on the differential diagnosis of auditory neuropathy in adults and children. This session promises to deepen our understanding of this challenging auditory disorder, highlighting the clinical features, diagnostic protocols, and management strategies essential for effective patient care. Please join me in extending a warm welcome to Dr. Vijay Kumar Narne as he takes the stage to share his invaluable knowledge with us. I now have the pleasure of inviting Mrs. Vinila and Mr. Vijay Shankar to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings.
Hello? Am I audible? Yeah. So my topic of presentation is auditory neuropathy spectrum disorders, differential diagnosis in children and adults. It's a very old topic, and I thought, what should I do with this topic, because it has been largely explored. Okay, so I was initially thinking, what should I present in this topic? So I came up with some weird ideas. So let's try understand these ideas. Okay, so my presentation is largely on some introduction to auditory neuropathy and differential diagnosis. I just give one slide on rehabilitation. Okay, there's nothing in that slide. I will only talk about it. So auditory neuropathy or auditory neuropathy spectrum disorders is a hearing disorder where inner ear can detect sound, but brain struggles to process the sound which is detected by the inner ear. Auditory neuropathy is characterized by normal outer hair cell function within the cochlea. However, auditory nerve function is disrupted or impaired. So it has been identified long back in 1996 and been explored by many investigators, but they don't have a clear conclusion. But one point to note, auditory neuropathy is not an APD. Please separate them, these two aside clearly, because auditory neuropathy is a severe condition and APD is a minor condition. If you put them in a spectrum, on a scale. Okay, on one end you have auditory neuropathy, which is the severe end. The other end is a minor condition, is called APD. So auditory neuropathy can be caused by many factors. Most of these studies are from the Western countries, so do not look in that perspective. Because the one big problem that what we study in the books about auditory neuropathy is it's mostly seen in children, infants with hyperbilirubinemia, or if they are premature. Okay, but if you go to our clinics, we don't see this. Okay, now I had this question from the day I started studying about auditory neuropathy. So I was thinking all along, what is this? Why only in India we see in the age range of 10 years and above? In the Western countries, all the studies are in children and infants, mostly infants, not even in children. So I met a person called Gary Rans. He is one of the expert in auditory neuropathy. So I asked him, what is the reason why we see only in adults, that is children above 15 years, 10 years and above, and you see only in infants. So he said, Vijay, logic is simple. In Australia and all the Western countries, health system, that is government provides free health only for infants and children less than 5 years. Okay, so all the university setups are expensive healthcare setups where you have extensive testing being done. Okay, now they don't do a private clinic is a cheaper condition where they don't do a complete expensive testing. They just do a pure audiometry, immitance audiometry. They fit a hearing aid and send the patient in an audiology clinic, a private audiology clinic. But in the university setup, they do a complete diagnostic profile and then they come to a diagnosis. Now that is very expensive. So all the patients don't go there. So those who are free go to universities. Those can't bear, they'll go to private clinics. So because government provides free of cost for the infants, so they only study infant conditions. Now in India, where I studied was All India Institute of Speech and Hearing, Mysore. So we don't get infant cases. We only get cases from age of 5 years and above. Infant cases are less compared to other cases. So because of that, we only see children above 10 years. And in Australia, US, they see only infants. So it is not that this condition does not exist in India for infants, nor that they don't have this condition in children about 10 years or 15 years. So this is a big difference. Okay, so whatever the factors that they list as the causative factors applies only to infants, not to the children above 10 years. So we don't have an appropriate or reliable causative factors, the cases that we largely see here. So I think all of you know where is cochlear pathology only restricts to the cochlear hair cells, outer hair cells, and later stages it may go to inner hair cells. Whereas ANSD is largely not in the hair cells, it is away from the hair cells, not really known by anyone where is the pathology, but hypothetically we say there are two conditions, presynaptic and postsynaptic in simple terms. So postsynaptic, if it is in the auditory nerve, it is postsynaptic. It is in the synapses, it's called presynaptic condition. They say presynaptic, but presynaptic is the inner hair cells. So I don't think it is in the inner hair cells. It's maybe at the synapses level or at the auditory nerve level. Now, if you understand this slide, then it is easy to understand the differential diagnosis of auditory neuropathy. So, in the normally when all the nerve fibers fire, so they'll have a slight jitter that is less than 0.1 millisecond. All the auditory nerve fibers, they fire almost at the same time. Okay, so because they fire almost at the same time, if you add them, we get an average response. Now, if there is a presynaptic condition or postsynaptic condition, so presynaptic condition, because there are not all the synapses are really working well, So only few synapses will work. So it simulates only few nerve fibers. So there are less number of nerve fibers are firing. So the potential amplitude is lesser. Okay, so this is what will happen in the presynaptic condition. In the postsynaptic condition, it is largely the myelin sheath which is affected. So the firing rate is largely random, not as it's supposed to be. So if when you add them, we don't get an added response clearly. Okay, so what is the diagnostic criteria are the tools that we use as supposed to be. One is otoacoustic emissions, auditory brainstem response, and BOA, VRA for children and adults, proton audiometry, and acoustic reflex testing. So these are the tests that are ideally told by everyone. And in addition to the otoacoustic emissions, they also say that we can use cochlear microphonics along with otoacoustic emissions to identify auditory neuropathy. So my discussion is going to be only on the topic of whether can we use either OAE or CM, or should we use only OAE. Okay. So this is the general flow chart which is followed in India. Okay, so please do understand, when we get a patient, infant, children, so we do click ABR. If the click ABR is absent, then we go for either TEOE, DPOE. If the TEOE, DPOE are present, then we say maybe having a auditory neuropathy. Okay. If in case OE is absent, then we do cochlear microphonics, that is ECOG. If you do ECOG, if the cochlear microphonics are present, then we tend to say it is ANSD, and if the ECOG is absent, then we tend to say SNHL. So this is generally agreed approach that is followed in India. Now there is one fundamental problem in this approach. Okay, so the problem is this. Generally, when they defined auditory brainstem response, or when we study about auditory neuropathy in the books, they say auditory brainstem response. They never say click evoked auditory brainstem response. So in the Western countries, it is a rule. It's a rule that you have to do click ABR and a tone burst ABR. If both are absent, and if the cochlear microphonics are present, then you can conclude it as having an auditory neuropathy, not just click ABR. Okay, so that was the misunderstanding that most of the Indian, when I was studying, this was the misunderstanding we had. So I did learn this later. Okay, there are around 15 cases that I have seen in the institute after I did my PhD when I was working as a faculty. I've seen 15 cases where they misdiagnosed a child as auditory neuropathy, but the child is not actually having auditory neuropathy. Child was, I think 5 of them are ethetoid CP. Okay, why ethetoid CP I'm highlighting is mostly ethetoid CP will have an high frequency sloping hearing loss, which is starting at 1K. Okay, and when you do a click ABR, it gets absent. Okay, and also if you do OAE will be absent. Only which will be present is the cochlear microphonics. Now, why cochlear microphonics present, that we will discuss later. Now, if you see a patient having a click ABR absent, so we did click ABR absent, OAE absent, so we observed a long ringing cochlear microphonics. We thought it is an ANSD. We diagnosed, sent the patient for the treatment. They gave some hearing aid, and they started giving a treatment. The therapist identified that child actually responds better to the low frequency sounds and not to the high frequency sounds. So because I was a therapist for the child, I was a supervisor to the therapist. So the child, the clinician brought the case to me and asked, "Sir, what is this? How can an ANSD can hear low frequency sounds?" They diagnosed it as ANSD. Then I thought, okay, let me read the file clearly, and I said, okay, let's try do ABR once again, click ABR, then tone ABR we repeated, and then we observed that actually child had a tone burst ABR present at 500 and 750, not 1000. So this is the first case that I've learned. And then I asked this clinician, get me as many cases as possible who are diagnosed as ANSD. Let us see. So out of some 50 case files, I identified 15 of them were actually being wrongly diagnosed. So then we published a paper using that data. Okay. So now from this, what I have learned is when you do ABR, when they define ABR in the book, do not consider it is just a click ABR. It is supposed to be click plus tone burst. Okay. So then I thought, okay, we can use cochlear microphonics, but only along with click ABR and tone burst, we can use cochlear microphonics. But later, by reading my publication, one of the professor, his name is David Staples. So he wrote he wrote an email to me. So he said, Vijay, this is fine. You should do click and tone burst ABR and cochlear microphonics. I do agree, but we should also understand where the cochlear microphonics are coming from. That is what his email is. So there is no details in the email. Then he said there is one old study done by Aaron. He showed that cochlear microphonics can be present in profound hearing loss cases. That is his email reads. So then I started exploring what are these cochlear microphonics are, that ECOG actually, and where this generates from and what is its story. So ideally, we consider simple presence of cochlear microphonics is now bearing overused to diagnose ANSD. So simply using cochlear microphonics as a diagnostic criteria is a simple overuse of it. So basically means that cochlear microphonics generation site as of today, we don't know. When we don't know the generation site, we can't say if the cochlear microphonics are present, it means outer hair cells are normal. When I don't know where I am from, you can't say I am from Chirala or Guntur. Right? And when we don't know where the cochlear microphonics are from, we can't say if the cochlear microphonics are present, outer hair cells are normal. That's the probably his question was. So there is a study based on the models developed on the cochlea and in vitro studies in the cochlea. Cochlear microphone is recorded from the round window is not from the outer hair cells. Argued that presence of cochlear microphonics does not exclude any outer hair cell pathology. So cochlear microphonics can be seen in outer hair cell pathology patients. That is, we can see in SNHL patients also. That is, the ethetoid CP has an SNHL, but he still had a long ringing cochlear microphonics. In contrast, the absence of otocoustic emission in such cases is consistent with outer hair cell dysfunction. So the basic question arises here is very simple. We are only saying OEs are absent. When the OEs are absent, it simply means outer hair cells are not normal. And then we are saying cochlear microphonics are present, so cochlea is normal. We are not being correct by ourselves. Okay, now the problem is, there are another problem. So people may say, no, we will only use when there is a middle ear pathology. So I am only talking in a condition when there is no middle ear pathology, if the OEs are absent, and if you use a cochlear microphonics present, then that argument is still a wrong argument, because we already said OEs are clearly from outer hair cells. When they are absent, it simply means outer hair cells are damaged. Now you can't say cochlear microphonics are present, so they are present. The cochlea is still normal. So that is an arguable question. Evidence that CA cochlear microphonics are not reliable. Several studies have now questioning the diagnostic criteria. It is proposed by ANSD, which is sometime in 2008 onwards. There is a large argument going in UK and US that the diagnostic criteria recommended by the authorities is not right. So basically they're questioning that when we do ABR, click ABR, and we say and cochlear microphonics are present, we are diagnosing it as ANSD, and it is simply wrong. So there are several studies, and they are even questioning the the people who defined the diagnosis. So it's still under investigation. So my simple suggestion is do not use cochlear microphonics as an indicator of diagnostic criteria in ANSD. Okay, then we may have several questions. So if the OEs are absent and if the ABR is absent, what should we do? Right? Simple. Let's take adults. Okay. You do an audiogram, then you do a ABR. If the ABR is absent, try do a tone burst ABR. If the tone burst ABR and the click ABR both are absent, and if the audiogram is showing a pattern similar to ANSD, and if their identification scores are poorer compared to their pure tone average, then we can conformably say it is an auditory neuropathy. In children, there are several issues here. One is maturation. Most of us do not look for maturation. As soon as the baby comes in, we jump to diagnose, which is not an appropriate approach, mostly for the kids. Okay, with adults, you can do anything, it's okay. Because they understand what is happening to their auditory system. So whatever you say, they will go and they decide what they have to do. With the children, the problem is we convince the parents, child has no rights, so child can't take a decision. So by the time we completely understand it, it is too late sometimes. Okay, because this is those 15 cases that I have seen, it was actually late for them. Okay, now what we can do is we can do a click ABR, tone burst ABR. If the both are absent, cochlear microphonics are present, OEs are present. Now, if the OEs are present, clear, no problem. If the OEs are absent, then do a behavioral observation audiometry, ask the parent to observe, write based on the click ABR, write a provisional diagnosis. Do understand it is a provisional diagnosis. It is not a complete diagnosis. It is still a provisional, which means you can still change it. Okay. And tell the parents that you suspect this is the problem, but you need further evaluation. Now, so there is another potential which can be used in auditory neuropathy. So let's try understand this first, and then we go and see whether it can be used for diagnosis or not. So role of cortical auditory evoked potentials, which is also been used for auditory neuropathy quite some time. So ABR is, now first try understand what is ABR and what is LLR from the perspective of recording. Okay. So ABR is consisting of 5 peaks which are separated by 0.8 milliseconds. Okay, that means any time delay in the firing of less than 1 millisecond can affect ABR. Right? So if there is a jitter less than 1 millisecond, it can affect ABR. So ABR will be absent. That is very clear from the perspective of auditory neuropathy. Now, coming to cortical auditory evoked potentials, they are separated by all the P1, N1 are separated by 40 to 50 millisecond, and N1 to P2 is almost 100 millisecond, 80 to 100 millisecond. So by and large, we can say 80 to 100 millisecond, they're separated by. Okay, that means any time delay greater less than 50 millisecond will not affect your cortical potentials. They are very robust potentials which can be averaged even if there is a large variability in the firing rate. But so that is the topic. Now let us come. How the ANSD behaves, or CAP behaves in ANSD. I had 2 studies. 2014 study, I had almost 198 patients where we looked at the CAPs in all of them. It's a retrospective study. So what we observed is CAPs can be normal, CAPs can be absent. CAPs can have normal latency with reduced amplitude, or they can also have prolonged latency with higher amplitude. All these 4 possibilities are observed in CAPD or CAPs in auditory neuropathy. Now, when these four are being observed in auditory neuropathy, so, and then I also tried looking at what is the relationship with the identification score. Conformably, we can say if the identification scores are good, most of them will have CAPs present. If the CAPs are absent, then the identification scores are poorer by and large, but there is 30% variability that still be there. So from this, we can learn that CAPs cannot be used for differential diagnosis because it can be present, it can be absent, it can be prolonged, it can be normal. So we don't know. So in that condition, using that for diagnosis is a big questionable issue. Second is CAP's behavior is variable in ANSD. So it's present in the majority of them, but it can also be absent. So CAPs can be used for deciding a hearing aid treatment or cochlear implant treatment, but not for the diagnosis. So rehabilitation, I don't know how many of you looked at these studies done in Australia. There is a study done for 10 long years. It's called longitudinal LOCHI study, in short. Okay, it's a longitudinal study. They recorded hearing aid benefits and cochlear implant benefits in children with cochlear hearing loss and also children with ANSD. And they looked at the language development and speech development in them. And their conclusion is this: auditory neuropathy patients behaves almost like ANSD. Okay, if you give a hearing aid, some of them do better. If you give a cochlear implant, some of them do better. It is almost like what you see in cochlear hearing loss. So they did not see a greater difference between them. So that's about rehabilitation, and there are several people started using cochlear microphonics, summating potential to say presynaptic, postsynaptic condition. They are very complicated issues. The basic problem is this: we don't know where these ECOG potentials are coming from exactly. Whether they are from the synapses, outer hair cells, inner hair cells, we really don't know. When we don't know that, I don't think we can conclude that, by doing summating potential, cochlear microphonics and all this and say that, they are presynaptic, postsynaptic. It is still preliminary. I am not very happy on that note, and there several studies have done it. No one is clearly using it. No country follows this procedure. Some researchers say that it helps, some say it doesn't help. So they're still fighting to say whether it helps or not. Okay, even if you say that that is right, they're still fighting. So I don't think that is right in any point. Okay, so these are the references that I referred to. And thank you.
Thank you very much, sir. Before we go forward, I would like to request chairpersons to give your views on the talk.
Sir, you said initially it was an old topic, but though it is an old topic, it is a very important topic, sir, because even today we see many cases of children and adults with auditory neuropathy, but we are not able to diagnose. As you said, now even with cochlear microphonics, then ABR, then CAP, it's very difficult to diagnose, sir. So many cases are coming. But today you have given us the information like what is what, like practically you have told us everything, which we don't even get it in textbooks. So that is what I have realized. And your presentation was very brief, very neat, and very beautiful, sir. It is completely into our brains. Hope even all the students have understood. So what are the practical issues that we face while diagnosing auditory neuropathy? So sir has beautifully explained the diagnosis, differential diagnosis. So we have to just take this information and implement it in our respective places. Thank you once again, sir. It was a very beautiful presentation.
Thank you very much, ma'am. I would like to thank Dr. Vijay Kumar Nane for that highly informative and insightful presentation on the differential.
So, my question is, that nowadays, since 3 to 4 years, from Australia and United States, many of them are doing for considering CI candidacy, cortical uh, uh, cortical aided test they are doing now. Okay, that is very useful, and it is helping for the candidacy. Okay, because instead of doing EABR, as you know, electrically evoked auditory this thing, because that is invasive procedure. So they are doing and they are getting good results there. That's what they say. Okay, is it? Do you accept with this, or do you have any comment? Uh, And what they say is, because it is clear cut information giving about presynaptic and postsynaptic. That's what they say about it. Hmm. See, my question is, for integrity of the nerve. Okay, so sometimes we may get some information ABR, click ABR, or sometimes we have to do tone burst ABR, right? So if we do not get much information, then we think about cortical,
Yes.
because the integrity. So
Yeah.
see, there also, if you do not get information, we used to do electrically artery evoked
Yes.
test. Okay, right?
Yes.
So or else pulmonary stimulation test, whatever.
Yeah.
Okay, so if you fail there, generally, okay, instead of doing EABR, clearly what they were saying, cortical, okay, aided responses we can do, we can get significant information in that. Okay, that is the replacement of EABR. Many people are commenting since 2 to 3 years.
Yeah.
Okay, so
Yeah. Now I understand. So probably they're trying to do CAPs from the after the implantation. We can start recording the potential cortical potential.
the prior to the surgery, actually.
Yeah. Prior to the surgery, you can do for the prior to the surgery. It is with the hearing aid. They do it,
Yes.
and
Yeah,
I know
correct,
it's
correct.
the system is called Ear Lab. It was to an extent good, but it has some technical issues in it, and this is not the podium to discuss those.
Even EABR also, it has got several, artifacts.
Yeah. So no, sir, it's not about artifacts. There is a technical glitch in the signal processing unit of the Ear Lab system, and that is why it was not very successful in all the countries. It's only in the Australia where the Harvey Dillon is working. So he promoted the system, and it was a good system. I completely agree.
NAL, right? National Acoustic Laboratories. Dylan worked on that, and he has proved it, actually.
Yeah. So, but there is a technical issues in it, and there are several others still question it. So, and I am one of them, and Terence Picton, David Staples, and there are few people in US. They still question the statistical tool they used and the filter setting they used for the recording them. So, I have my own reservations.
Okay, fine. Yeah. Thank you.
Are there any more questions from the participants?
Sorry, sir, I think it is not relevant to the topic or not, but regularly we are facing some issues, sir. See, some doctors used to prefer OAE PTA impedance in sudden hearing loss cases, sir. So by doing PTA and by doing spin test, we could be able to diagnose retrocochlear pathologies there or not. But their point, they're telling something that I couldn't understand exactly, sir. So OEE places a major important role in sudden hearing loss to determine labyrinthine disorder, something like that. So can you explain about that, sir?
I did not understand your question clearly. You said there is a OEE.
Role of OAE in sudden hearing loss patients to determine the labyrinthine disorders or
I don't have information on that. Yeah, if I get some information, I'll share with you.
Thank you very much, sir. Your detailed explanation of the nuances in diagnosing auditory neuropathy and the differentiation between adult and pediatric cases has provided with a clear perspective on this complex condition. So I would like to sincerely appreciate your time, effort, and dedication in sharing your expertise with us today, sir. Thank you very much, sir. So with that, I would like to invite now Mr. Gopi Venkatesh to hand over the token of appreciation to our esteemed chairperson, Dr. Vijay Kumar Narni. I would like to request our chairpersons to join, sir. I would like to request Dr. Vijay Kumar Narne to hand over it to both the chairpersons. Thank you very much, everyone, for your contribution. So let's move forward. So now it's my honor to invite our next speaker, Dr. Neeraj Kumar Singh, who is an associate professor at the Department of Audiology, All India Institute of Speech and Hearing, Mysore. He is a distinguished academic and researcher whose contributions to the field of audiology are exemplary. He completed his bachelor's and master's in speech and hearing from ISHA, followed by a PhD focusing on the frequency tuning properties of ocular vestibular evoked myogenic potentials under the guidance of Dr. Animesh Barman. With an impressive portfolio of over 66 peer-reviewed publications in leading international journals, he has established himself as a pioneer in vestibular research. His work has garnered numerous accolades, including 25 awards for scientific paper presentations, and he has shared his expertise at over 100 national and international conferences. In addition to his research, he is the associate editor of the Journal of ISH and has contributed extensively as a reviewer and editor for multiple scientific publications. He has successfully secured research funding totaling approximately 3.74 crores INR from various prestigious agencies, demonstrating his commitment to advancing audiological sciences. Today, he will be speaking on a vital topic, diagnostic value of vestibular evoked myogenic potentials. His presentation will provide us with a comprehensive understanding of VAMP's role in vestibular assessment, its clinical applications, and its significance in improving diagnostic accuracy for vestibular disorders. Please join me in giving a warm welcome to Dr. Neeraj Kumar Singh as he shares his valuable knowledge and insights with us. Now, I would like to invite Mr. Sampath and Mr. Abhishek to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings. Thank you.
Good afternoon, everyone. I hope I'm audible to everybody at the back. Yes. Yeah, thank you. Thank you for that attention. So this topic, of course, I was given by the organizers, but it's inspired by a lot of comments from a lot of renowned researchers who have finally given up their belief in WEMP. And some of them say that it really doesn't help. So I would like to drive home the point from my presentation that if you take care of certain specific things that I'm pointing out, this is not an exhaustive presentation on WEMP. Rather, I am trying to point out at certain specific mistakes which people do. These are subtle mistakes which you make. But when you make those mistakes, it makes the diagnosis go completely wrong. So if you do not make those mistakes, believe me, you will find benefits from doing WEMP. So at the outset, before I begin my actual presentation, I would like to say a disclaimer here that there is no financial relationship or any kind of relationship with any manufacturer of any of the equipments whose pictures you might see in my presentation. They are purely meant for educational purposes. All photographs in the presentation that I have used are all taken with prior permission from the participants on whom I have taken permission. I must thank the organizers of APASLP Con 2025 for inviting me here, and I would be left behind in my duties if I didn't thank the director Aish and the HOD Audiology for allowing me to come here so that I can share my whatever little expertise that I have in the vestibular disorders. So I would begin very quickly with the basic aspect of why a sound can induce a vestibular response. So if you understand that the entire inner ear consists of cochlea as one part, and there are 5 different parts which are the vestibular end organs. There are 3 semicircular canals and 2 otolith organs. And the way the stapes foot plate is located, we all, while we are learning, we learn, okay, it is there on the promontory inside the oval window, but we never thought that oval window is lying where, exact location of that. It lies right above the utricle and saccule, not into the cochlea. It lies above the utricle and saccule. Therefore, any fluid movement that it creates is likely to initiate a vestibular response. But then you might think, why does it not initiate a vestibular response at low levels? So it does not initiate at low levels is because of the high resistance path that the vestibular system has. There is no opening on that side. Whereas on the cochlear side, you have the round window. So because of that, the resistance towards the cochlea is low, and therefore when the sound energy is low, all that flows towards the low energy path. When the sound energy is high, it can overcome the high resistance that the narrow channels in the vestibular system are posing, and therefore the sound will flow, the energy will flow towards that side, and that will stimulate vestibular end organs. So whenever the sound energy is high, it's like a shock wave being exerted towards the vestibule, and that shock wave is the reason why WEMPs are produced. So we can have several kinds of WEMPs. There are 2 major clinical subtypes and 1 emerging subtype, and then there are quite a few types of WEMPs which are beginning to emerge. There are 1 or 2 studies on others, but I would say 2 major clinical subtypes and 1 which is probably having a potential to become a clinical subtype. So the 2 major clinical subtypes are ocular vestibular evoked myogenic potentials. When we place electrodes below the eyes, we can record them. And then cervical vestibular myogenic potential, which is when we place the electrodes on the neck muscles, we can record them. The third one is the masseteric WEMP. So when we place electrodes on the masseter muscles, we can record them. And that's the emerging clinical subtype because it's showing promising results with whatever initial studies are being done, and the clinical studies are also being done. But then the one which we are using regularly in the clinic are C-WEMP, cervical WEMP, and O-WEMP, that is ocular WEMP. So now, yeah, okay. So the OVEMP is actually an excitatory potential. So just this is a general convention that whenever you have an excitatory potential, it will also always produce a negative peak first. And whenever you have got an inhibitory potential, it will produce a positive peak first. So when we record CVEMP, it produces a positive peak first, which implies that it is an inhibitory potential. So what does it inhibit? When we give loud sound to the otolith organs, it inhibits the activity of the muscle. So the muscle produces EMG, and this continuous EMG activity is getting inhibited, and that causes the CVEMP response, which will have a positivity first. OVEMP is actually augmenting the activity of the muscle. So it's instead of inhibiting it, it augments. So therefore you find negativity first. So these are the different potentials. As I said, there are two different ways in which you can record CVEMPs. One is just a head turn, and the other one is just with a neck elevation when the patient is lying down. OVEMP can be recorded with electrodes placed under the eye. Yeah, I'm sorry about that. That's not my fault. So OVEMP is with electrodes placed under the eyes when the patient is gazing upwards, looking up during the recording, and masseter muscle will be for MVEMP. So we can record these potentials with loud sounds, but we can also record it with vibration, so bone conduction, and we can also record them with electrical stimulation. So there are two kinds of electrical stimulation that are possible. One electrical stimulation is called as the galvanic VEMP, where we use an anode and cathode and we stimulate the scalp. The other one could be possible through cochlear implant electrodes. So when you pass sound through the cochlear implant, even that can work as an electrical potential. So you can record even through that. So why do we have to learn about VEMPs? There are many reasons, okay? But the most significant reason is for utricle, there are only some 2 or 3 tests which can test the functionality of utricle. And the macular region cannot be tested by any of them. So the macular region of the utricle can only be assessed if you use OVEMP. And there is absolutely no other test other than CVEMP to assess the functioning of saccule. Now, if you think that the vestibular system has got 5 end organs, 2 of them are utricle and saccule, and CVEMP and OVEMP are the only way to assess them, then we must be learning about them. Otherwise, we will be assessing only the semicircular canals and not the otolith organs. That means I would never be able to make an assessment of a patient who is having difficulty in, say, translational movement, linear accelerations, in all these places, or while bending down, sudden head tilts. All these issues, all these conditions are creating a problem. We won't be able to make a diagnosis in such patients. Another important thing is this is a non-invasive test. Now, non-invasive, what I mean by non-invasive is in comparison to, say, a caloric test. So in a caloric test, when we are giving water irrigation or air irrigation, there are chances of vasovagal stimulation. For some people, it could be inducing huge amount of dizziness and all that, whereas when you do VEMPs, nothing of that sort happens. So it's non-invasive. It's very quick. Including the electrode placement and recording from both sides, it would not take more than 15 minutes for you. So within 15 minutes, you can finish assessing both utricle and saccule. And some conditions like superior canal dehiscence, means people with a Tullio's phenomena. I hope everybody knows what a Tullio's phenomena is. It's loud sound induced vertigo. So whenever people have, may I have water please? So whenever people have a loud sound induced vertigo or pressure induced vertigo, somebody tries to clear the nose and feels vertiginous. In such cases could be an SCD or third window syndrome. Let it be there, I'll use it. Third window syndrome. So in all such cases, VEMPs become very important. And finally, it helps us in a lot of cases with Meniere's disease, where the presenting symptoms are not classical. So I will describe how it helps a little later. So let me begin now quickly with the individual parts, which is CVEMP. So CVEMP it's a short latency potential recorded from the SCM muscle. SCM is sternocleidomastoid muscle. So from the SCM muscle, so you have to place an electrode on the belly of the SCM muscle and where the SCM muscle is inserting into the sternoclavicular junction, there the reference electrode will be placed and we record a response. So this is the typical response that you see over here. I hope you can see the pointer. Can you? No. Okay. So on the right side, top right corner, you can see two recordings, two waveforms. So they are typical CVEMP responses with positive peak first, followed by a negative peak. And the positive peak has an average latency of about 13 milliseconds. It could vary from 12 to 16 milliseconds. And the negative peak has an average latency of about 23 milliseconds. The peak to peak amplitude would depend upon whether the way you record it. So if you just plainly record using an ABR equipment, you can have a large variability going from 20 microvolt to 350 microvolts. Whereas if you use a proper WEMP equipment and do something called as a EMG normalization, you should be getting a response less than 10 microvolt. So you can do that, and the threshold typically is about 75 to 85 dB NHL. So that means where the ABR would end, you are basically beginning there. Just to put it into context, we normally do ABR at 80 dB NHL or 90 dB NHL. That is the threshold of OVEMP. So you need to go higher than that to get responses in everybody. So that is high. And when we compare between the two sides, we get a slight asymmetry even in normals. So if the asymmetry crosses 31%, then we say it's a clinically significant result. And then when we compare between frequencies, say if I recorded, just before this, Vijay sir was talking about click evoked and tone burst evoked, right? So here we do not use clicks, we use only tone burst. But if we use a tone burst of 500 hertz and a tone burst of 1 kilohertz, and if we see the relationship between their amplitude, that is called as IFAR, interfrequency amplitude ratio. So it's the ratio between two different frequencies. So if that ratio is high, okay, if it is greater than 1, it's pathological indication. If it is less than 1, it indicates that it's a normal condition. So now I was saying that there are a few pointers I would want to say, because now it is very easy to learn WEMP. You can have a number of YouTube videos to learn WEMP. So it's not difficult to learn WEMP. But what you need to take care for you to make accurate diagnosis is, one, the precise electrode placement. Okay. So don't worry about going through all these waveforms. There are a lot of waveforms. Don't worry about that. What you need to understand is the 60% point, okay? When we divide the muscle into several different points, where 60% point comes, that is the most critical point for positioning the non-inverting electrode. And if you were to miss that placement by mere 2 centimeters, means you go 2 centimeter up or 2 centimeter down. So say for example, on the right side you placed it at 60%, and on the left side you placed it at 60 plus 2 centimeter, 60% plus 2 centimeter, or 60% minus 2 centimeter. Despite this person being normal, he will show an abnormal result. So that is very important. So the placement should be precise at 60%, and it should be precise on both sides. You cannot afford to be precise on one side and not so precise on the other side. So if you have to make an error, it has to be the same error on both sides for it to stay symmetrical. So that's the take home message. So 60% is the most accurate way. You might ask me how to do that. You can measure the muscle beginning from here, going up to the mastoid, take the entire length and just look at the 60% of that, put a marker and then clean that place and put the electrode. So it's not difficult to do. It's very easy to do. Just with a simple thread you can do it. You don't even need a centimeter marker or something like that. So that is important. Okay. The next is, we can, the way we activate the muscle also makes a difference. Okay. So one way to activate is just by rotating the neck away from the side where we are stimulating. So if I'm stimulating the left ear, the neck will be rotated to the right side. If I'm stimulating the right ear, the neck will be rotated to the left side. So this will activate muscle on one side. The other way to do it is when the person is lying down flat, I ask that person to elevate head. So that will activate muscle on both sides, and it allows you to record bilateral VEMs if your equipment has the facility to present stimuli on both sides. So you can get bilateral VEMs, but it is more taxing this way. The supine position with head elevation. All those who have tried losing weight and tried to reduce tummy fat, you do this exercise, right? You try to lift your upper body or the torso again and try to keep the lower body on the ground, isn't it? And doing it 10 times is very difficult. You have to stay in this position for 40 seconds continuously, and then a repeat 40 second, and then on the other side 40 plus 40 second. This is the bare minimum you would do, even if you're recording single frequency response. So that means for that much time it is more taxing. It's easier to do with neck rotation. It doesn't tire it so much. So activation is fine, but how do I control the amount of activation? Because when you keep turning the neck, as soon as you start turning the neck, it starts creating tension in the muscle. But the more the neck is turned, the more the muscle tension is created. So this is like just understand this example. If you are standing on the ground, I know what your height is exactly. But if you are standing on the 3rd story building, and I am taking the height from ground to the 3rd story building and your height, it's very difficult to estimate your height alone, because the total height is building's height plus your height. So when we record the CVEM, it is actually the EMG plus VEM. So it's very difficult, because if the EMG is more, the amplitude is more. EMG is less, amplitude is less. If I have a way in which I can remove the effect of EMG or keep it constant, if I am comparing, say, one person's height who is standing on 3rd floor and one person's height who is standing on 5th floor, it becomes difficult. But if I want to compare two people's height, but they are both standing on 3rd floor, it is easy, because 3rd floor cancels and only your heights are remaining, right? So we can do something like that. So EMG normalization is that procedure by which we can do that. So it identifies the baseline. Baseline is before you give the stimulus. So before I give auditory stimulus, there can't be an inhibition in the muscle, right? So when there is no inhibition in the muscle, then we've got only EMG. And after the stimulus, EMG is there, and along with that, the response is also there. So when I subtract the pre-stimulus, which is without the stimulus, subtract pre-stimulus from post-stimulus, it will cancel the EMG. And only thing that will remain is the CVEM. Okay, so that is one way of it shows target EMG. Okay, so in the first one, the average EMG is 100 microvolt. In the second one, the average EMG is 200 microvolt. In the third one, the average EMG is 300 microvolt. And in the fourth one, the average EMG is 400 microvolt. And can you see the amplitude rising? These are unrectified responses. When you rectify these responses, okay, what happens is the bottom right corner, okay, you see the same EMG levels are there, but when they are rectified, because the EMG is taken away, it's like 3rd floor cancelling, 5th floor cancelling. So no matter how much was the floor, if you cancel that, the actual height will be gained. So that is the effect of using a EMG monitoring. If you do not use that, you will make mistakes. This is an example of that mistake. The first one is unrectified, uncontrolled level of EMG. So see, there looks an asymmetry, right? The right ear amplitude looks bigger and the left ear amplitude looks smaller. Just barely looking at it, you can realize that. When I rectify it, that is correct the baseline, then you see the two. They look very symmetrical, right? So if I didn't do this, I would have diagnosed this patient as having a vestibular asymmetry, left-sided problem. But because I did the control, now I know there is no left-sided problem. Both ears are similar results. So this is the basic protocol. The basic protocol is to use a 500 hertz and a 1000 hertz tone burst. You must use rarefaction polarity. Don't use condensation or alternating. although polarity really has no effect on the air conduction VAMPs, but on bone conduction it has an effect. So therefore, use only one kind of polarity, which is rarefaction polarity. Use, and if your instrument gives in NHL, use 95 dB NHL to elicit VAMPs. If it gives in dB SPL, then you use 125 dB peak SPL. 5.1 rate, 2 millisecond rise fall time, and 1 millisecond plateau time, and use an amplifier gain of 5,000. This is unlike ABR. For ABR, we use 75,000 to 1 lakh times because it's a very tiny response. VAMPs are very robust responses. Just 5,000 times amplification is good enough to give us a very good result. So that, and a filter set of 10 to 1500 hertz. Now, if you do that, these are the clinical applications. I've tried to put just the summary of it. If I had enough time, I would have discussed one by one, but it's very simple to understand. You see the pathologies: Meniere's disease, BPPV, superior canal dehiscence, labyrinthitis or neuritis. All these are peripheral vestibular lesions. And what you see across indicates no effect. So no effect means the latencies are not affected in them. So whenever you've got peripheral pathologies, latencies are not affected. Whenever you've got neural pathologies, that is auditory neuropathy, multiple sclerosis, vestibular migraine, or vestibular schwannoma, in all of them, the latencies are likely to be prolonged. So when there is a neural pathology, only the latencies get prolonged. When there is a labyrinthine or peripheral pathology, you don't have a latency prolongation. Amplitudes will be affected by all of them. But in cases with Meniere's disease, there is a chance of amplitude increasing in the affected ear. Means if somebody has got a right ear Meniere's disease, you can see a larger amplitude in the right ear. You can also see a smaller amplitude in the right ear. That is because it depends upon the stage of Meniere's disease. If you are seeing the person at an early stage of Meniere's disease, then what will happen is, because the saccular membrane distends because of the endolymphatic pressure, it comes closer to the stapes foot plate. So very effective energy transfer. And that's why you see larger amplitude. In later stages, there will be a lot of hair cell degeneration. So even though the amplitude transfer is effective, it cannot be utilized because the hair cells are not working properly. So because of that, you could see a reduced amplitude. So that happens only in case of Meniere's disease. It doesn't happen in any other pathology. All other pathologies, you will see reduced amplitude. In terms of the threshold, you will see the thresholds becoming worse. Upward pointing arrow means larger number. So when the threshold has a larger number, you know it is worse, right? A 10 dB threshold is better than a 25 dB threshold, isn't it? So a 25 dB threshold is bad in terms of hearing. Likewise here also, a 125 dB peak SPL threshold is worse than a 110 dB peak SPL threshold. So larger number is what indicated here, and you will see thresholds getting worse in all conditions. Okay. The asymmetry ratio is the comparison between the two sides. I said 31% or more asymmetry ratio. So in all unilateral vestibular pathologies, like a Meniere's disease is a unilateral vestibular pathology, or say a labyrinthitis is a unilateral vestibular pathology, a neuritis is a unilateral vestibular pathology. So in them, you will see high asymmetry ratio. In bilateral pathologies, you will see no significant asymmetry. So that frequency tuning is a marker for, it's almost a biomarker for presence of endolymphatic hydrops. That means if you see a frequency tuning of 1000 hertz, meaning we are getting larger amplitude for a tone burst of 1000 hertz than a tone burst of 500 hertz, then I can be quite sure that it is Meniere's disease, provided person's age is less than 50, because age can also affect that. So for older age, we have to look at that ratio with the age related norms. Next, we are going to OVAMP. Okay. So again, typical OVAMP response is exact opposite of a typical CVAMP response. We get a negative peak first, followed by a positive peak. So that is because it is a excitatory potential, and this is slightly earlier in latency. The CVAMPs were 13 and 23. The OVAMPs are 10 and 15. So the latencies are slightly earlier. The thresholds are similar, slightly higher in cases with OVAMP, because the distance of the utricle is little more from the stapes foot plate than the saccule. And asymmetry ratio is considered as 40, up to 40% is considered normal. The frequency tuning and frequency amplitude ratio will both be just like how it was in CWAMP. So CWAMP was a strictly ipsilateral response, meaning if you placed electrode on the opposite side, you will get nothing. There will be no response at all. But OWAMP, when you place electrodes here versus here, you still get a response. So it is a bilateral projection. So that's why you will get. But contralateral is a robust response. So while CWAMP, we are placing electrode on the same side as CM. While recording OWAMP, we will place electrode on the opposite side below the eyes. So that is the take-home message from here. Contralateral response is more robust and more often present. More recently, we've been doing a lot of work on identifying which is a better electrode placement, because for CWAMP, what we use is called as a belly tendon montage, because one electrode is placed on the belly of the muscle, the other electrode is placed on the tendon of the muscle. Why should it be different for an OWAMP? What we are doing is, when we are placing an electrode here and another electrode just below that here, we are placing one on the belly, but the other one is not on the muscle at all. So if WAMPs are produced better with a belly tendon, then ideally OWAMP should also be that. So on that logic, when we place on the belly and on the tendon of the muscle, this is called as the belly tendon placement, and this is called as the IO placement. One below the other is IO. And BT is when we place one on this side of the eye and one on this side of the eye. So BT produces much, much better responses. This is work of my PhD student, for whom I am the supervisor. And we have found that the BT montage produces almost 3 times higher amplitude sometimes than the IO montage. So there are very good implications of that in pathological cases where a mere absence will give you nothing. If it is present, you can know about its latency, you can know about its amplitude, you can know about its frequency tuning, so you will have a lot more characteristics to play with. When it is absent, you only have an absent response, that's all. In older individuals, OWAMPs tend to be more absent. So with BT, we found it is more often present. And therefore, BT is a better recording thing. So although right now it is not being used clinically because we have to produce more clinical evidence before it is accepted, but the day is not far. Maybe next 2 years or so, you will start using BT only for recording OWAMPs. Next, an important parameter is gaze elevation. So when the way I said, when you turn the neck by 30 degrees versus 45 degree, it changes the EMG. Likewise, when you look up by 10 degrees versus 20 degrees versus 30 degree, it also changes the EMG. And therefore, it will produce larger responses. So we recommend that it should be at least 30 degrees of eye elevation. So when the person is sitting and looking up, you either ask him to look maximally upward as much as he can, or put a pointer which is 30 degrees at 30 degrees elevation compared to the eye and ask the person to look there. So that is important. If you do not take care of that, sometimes he's looking 30, sometimes 20, then again it will create a difference in your recording. So you should not be making that mistake. So this is the basic protocol. Most of the protocol between CWAMP and OWAMP is same, except that you use a filter setting of 1 to 1000 hertz. And if your equipment has a facility of using a high pass filter of 0.1 hertz, use that because it's more of a low frequency response. And the amount of amplification that we do. So for OWAMP, for CWAMP, we did a 5000 times amplification. For OWAMP, we will do a 30,000 times amplification because it's coming from a smaller muscle. The eye muscle is much smaller than the neck muscle. So therefore, it produces smaller amplitudes, but it is still much larger than the ABR. So that's why 30,000. Now, these are the clinical applications of OWAMP. Now, for latency, it's the same. Labyrinthine pathologies will have no latency issues. Latency issues will be there only in the neural pathologies. The amplitude variations, most pathologies will have a reduced amplitude. Only in cases with Meniere's disease and in cases with BPPV, you could see a bilateral deflection of the amplitude. Meaning in some people, the amplitudes may reduce on the affected side. In some others, it may increase. So for Meniere's disease, the explanation is same. Utricular distension between early stages and later stages. But for BPPV, that explanation doesn't hold good because the pathophysiology is not that. So for the BPPV, the reason is the otoconia particles that enter into the semicircular canal resulting into BPPV as the pathology come from utricle mainly. So when they come out of utricle, they reduce the mass of the utricle. And when a lower mass body is vibrated by the same force, it will vibrate a lot more. And that's why you could see a larger amplitude. So you might say, then always it should be larger. Why is it showing smaller sometimes? When you have a significant amount of otoconia particle coming out from there, it is causing a degeneration there, right? So the neural cells will not be working appropriately, and that's why there could be a reduction in some people. All other concepts, including the asymmetry ratio, IFAR, will be same as that for CVEM. That means in Meniere's disease, you will have 1000 Hertz as the frequency tuning. IFAR will be higher in Meniere's disease. And the asymmetry ratio in unilateral pathologies will be more. It will be more than 40%. So that's that. One big advantage of using an OVEMP is picking up third window pathologies. Okay, so third window pathology means there are three best known third window pathology. One is superior semicircular canal dehiscence, in which case the bone plate on the superior semicircular canal is a small part of it is missing. It could be congenital, or it could be because of an accident, or it could be during a ear surgery, including a say conductive pathology where they are doing a mastoid surgery and all that. It could cause that. So those are iatrogenic causes, but all those could cause. The next is perilimb fistula, and the third one is a congenital pathology called as enlarged vestibular aqueduct syndrome. So those who are working with cochlear implants will know this terminology really well, because a lot of cases of cochlear implantation, when they undergo a CT scan, this is one of the findings. So in such cases, you could see overstimulation of the vestibule. And here, OVEMP is important, not CVEMP. CVEMP just tells you large amplitude, but OVEMP tells you large amplitude plus its frequency specificity is important. You get presence of OVEMP at 4 kilohertz, means when you give a tone burst of 4 kilohertz, and if that produces an OVEMP which is robust, more than 4 microvolts of amplitude, it has 100% sensitivity and specificity as per the published literature. And published literature are 4 so far. 4 different studies have published same finding, 100% sensitivity and specificity. So that means if you use a 4 kilohertz OVEMP and the response is robust, and the person is complaining of a Tullio's phenomena, then you can be absolutely certain. In fact, when they compared it against the CT scan, this had a better sensitivity and specificity than the CT scan, including the HRCT we are talking about. The HRCT sometimes did not detect, but the person was symptomatic and WEMP showed that. So this is a very important finding. Okay, so presence of a 4 kilohertz OVEMP is a hallmark of superior semicircular canal dehiscence or any of the other third window syndromes. So this is an important finding. So, but 4 kilohertz OVEMP we do not perform regularly. We perform it only in cases where we see a very large amplitude WEMP for regular thing, or the person has a symptom where they have pressure induced vertigo or loud sound induced vertigo. So only in such cases we use it. So with that, I complete my presentation. Thank you.
Thank you very much, sir. Now I would like to request the chairs to give your views on the talk.
It's my pleasure to chair my teacher's talk, and his talk is like reading Gelfand again and again. Whenever I open it, I learn something new, even though I have heard his lectures several times. So it's a pleasure, sir, to have you here at ASLPA Con. Thank you, sir.
Thank you.
Are there any questions from the participants? Yes.
Sir, you told about to see the corrected amplitude, right, sir? Do we have a normative for the corrected amplitude to say if it's hypofunctional or hyperfunctional?
Yeah, the corrected amplitudes are typically under 5 microvolts. So if it is more than 5 microvolt, I will say it is a hyperactive pathology like an SCD, or in such cases you can get a very large corrected amplitude. A hypofunction is defined as less than 2 microvolts. But we never take hypofunction or hyperfunction as a standalone condition. We always compare it with other ear. So that will be like a large asymmetry. So a hypofunction is when a large asymmetry ratio is seen, and then we look at higher or lower amplitude. So a combination of the two. It indicates hypofunction. No, 2 to 5 microvolt. 2 microvolt as the lower and 5 microvolt as the upper. So in between these two, if it is there with no asymmetry, then we say it is normal. If there is asymmetry, despite it being within this much, we say it is abnormal. Less than 2 microvolts.
Thank you very much, sir. Are there any other questions? Yes. I would like to thank Dr. Neeraj Kumar Singh for your comprehensive and enlightening presentation on the diagnostic value of vestibular evoked myogenic potentials. Your in-depth discussion has not only clarified the technical aspects of WEM, but also highlighted its clinical importance in diagnosing vestibular pathologies. I would like to thank you once again, sir, and I would like to request Mrs. Harshini Harika. I would like to request Mrs. Harika to join us to give the token of appreciation to our speaker, Dr. Neeraj Kumar Singh, and also I would like to request our chairpersons to join us. I would like to request speaker Dr. Neeraj Kumar Singh, sir, to please hand over the token of appreciation to our chairpersons for chairing the session. Thank you.
nanti artikel backdrop సర్లే అదన్నా అందులో
I will send now. One second, wait. All of you look here. Where is my? One second, wait.
Thank you for support, sir. You have given us a very great support. And thank you, students, for supporting us and for coming to the conference. And I would like to welcome Srinivas sir to come and all the ex-students of electricals to come on stage.
Thank you. Please come back. All of you look here. One second, sir. Wait, look here. Thank you, sir.
తీసే దాని మీద ఏంటి
Of the day and also of the conference, I would like to invite Dr. Sunil Kumar Ravi. It is my privilege to welcome you, sir. He is Assistant Professor of Speech Pathology at King Khalid University, Saudi Arabia, to deliver his talk. He brings over 15 years of extensive academic and clinical experience, specializing in bilingual aphasia, neurogenic communication disorders. His significant contributions to research and clinical training are well recognized internationally, with numerous publications and awards to his name. He'll be speaking on management of apraxia in adults. Please join me in warmly welcoming Dr. Sunil Kumar Ravi to the stage. I now invite Mr. Durga Prasad and Mr. Dinesh to please come forward to chair the session. We are delighted to have you with us and look forward to your insights and leadership during the proceedings. Thank you, sir.
Yeah, good afternoon, one and all, or good evening. Uh, this presentation will be like very brief. I know all of you are exhausted, okay, and I try to make it a little faster. Yeah.
Hello.
The today's topic of my presentation is about the management of apraxia in adults. This is one which is seen majorly in the neurocommunication disorders, especially it can be associated with patients with aphasia or the stroke patients in very commonly. And we all know that it is a disorder in which there is a error or a deficit in the planning and programming of the speech motor control. And it is very or quite distinct between from aphasia and also the dysarthria, which are characterized by the language disorders and also the dysarthria with the weakness of muscles or other systems. And the management has been like very, it is getting more and more attention with especially the prompt certification. I know many of the speech pathologists have been involved in the getting the prompt certification and involved in the training of or the treatment of apraxia. So what are the goals? Like, why do you treat? So we all know that, okay, this is especially in adults, it is caused due to some kind of neurological impairment. So what is the goal or what is your aim when you have a patient with apraxia? So what you are going to do, your goal is to maximize the communication effectiveness. So whatever the communication that they have, to improve that to the maximum, and the efficiency of the patient to produce the good speech and also the improve the naturalness of communication. Now here we have like any neurogenic communication disorders, we follow the two systems. One, to work upon the restoring the lost abilities, or in case if the patient is having very severe deficits, we might rely upon the compensatory treatment approaches like your AAC and other things. And we are going to make the patient to adjust for the permanent speech limitation, and this is the condition which is going to be common for most of your adult neurogenic communication disorders. And there are certain factors which can influence like what is the patient's improvement. Like suppose you have a patient comes to you and you say the patient requires speech therapy or the management. Now the next question the patient is going to ask you about for how long and how much improvement that I'm going to get it. Now none of us can guarantee for any patient whether he is going to get improvement in 90%, 50%, 40%, nothing like that. There is no standard way or standard criteria to say that, okay, this patient is going to improve this much and this is this much and all that. And this is due to there are so many factors which are involved in the management process. The first and foremost thing that you are going to see is about the severity of apraxia and also the chronicity, that is after the onset of the disease or the stroke, after how many months or the years that you are going to start your treatment. And also most of these patients with apraxia in adults, especially, they are going to co-occur with aphasia or also the other cognitive deficits. And the most importantly, the patient's motivation, because it is not the one thing which is going to be treated in a week or 2 weeks or 3 weeks. It requires long-term management. So the patient should have the continuous motivation in order to get improvement and also the patient supporting environment. And most of these patients, like I said, they are going to have the aphasia also. So the influence of aphasia is going to be a major factor, especially in the treatment of management of apraxia. And this is going to make it very hard to distinguish between apraxic and aphasic errors. And suppose if you come across that the patient is having aphasia, try to treat aphasia first and then slowly introduce the treatment of apraxia in it. And the early treatment is always better. So it is same like in any other communication disorder. And we are going to, even the chronic cases can also get benefited out of this. and treatment should be ongoing until the patient gets better with the generalization and also the retention of what are the skills that they have achieved. You need to keep them attended. And there are some cases with the progressive or the degenerative conditions where you might see the apraxia. Those people require long-term interventions, and they may also require other compensatory like AAC methods. Now, the overall, we have the three types of intervention. Although the first two are not very, it is not proven. The most of these patients are going to be benefited with the behavioral approaches. The medical intervention, there is no specific pharmacological or the medical treatment or even the surgical treatments are not available right now for the apraxia. And there can be indirect benefits from treating the underlying pathology. That is, if the patient has got stroke, and because of that, if apraxia is seen, then try to treat the stroke and its consequences. And there are some experimental drugs which are under investigation, but not yet proven with efficacy in improving the apraxia behaviors. Prosthetic and AAC approaches. Prosthetic, these are very rarely used except in the severe cases. However, they are known to have the limited benefit unless it is paired with the behavioral management, that is your speech and language therapy. Now we are going to talk about this behavioral management focus, where the speech and language therapy is going to be the most effective strategy, and it's a primary treatment approach. And here we are going to target about the articulation and prosodic abnormalities. And most of us, both the student clinicians and also the professionals, the minute you get a patient with a neurogenic disorder, they always start with the oromotor exercises, non-speech exercise and all that. This may not help you in treating the apraxia. They may work out for dysarthria, especially because they are known to have the either weakness or the spasticity or the flaccidity and all those things. But apraxia may not get benefited with this particular type of non-speech motor tasks. So more focus should be on the functional language and also the day-to-day communication words as soon as possible. And most of the treatment approaches of the the apraxia is based upon the motor learning principles. So these are the principles which are going to tune the neural mechanisms. Some of the proven things are the drill, that is your treatment should be intensive and systematic in nature, and the patient should be given opportunity to self-learn and also provide feedback regularly, and this will also improve the generalization to the patient. And we have something called as blocked versus random practices. That is whether, now for example, if I have a patient and if I say, like, ask the patient to repeat pa 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 pa, so it is the same consonant or the same word that is getting repeated multiple times. That is what we are going to call it as blocked practice. Now the second one is something called as random practice. It is not the only pa 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 which is going to be repeated. You add another syllable or another sound into it, like you say pa 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 and in between you say ka, and then so this is what we call it as the variable practice. And for the patients with apraxia, the second one, that is the random practice, is going to be very, very effective compared to the blocked practices. And speed accuracy trade-off, so try to use the very slow rate in the early stages of your treatment, and this has something to do with the planning for the speech motor movement in the patient. And as the patient gets better, you can alter the speech rate. And you need to provide feedback, but that feedback should not be 100%. So maybe you start giving like 50%, 60% of times you provide the feedback to the patients, and the remaining time the patient, he himself should be able to identify whether the word, whatever he said, is correct or incorrect. And don't just use the same set of stimuli on everyday basis. You need to have a stimulus selection carefully, and also how you are going to order them, that also is going to matter. And the factors which can affect this particular responses from the patient can be if you are using real words or the nonsense words, if you are using the high frequency words or the most commonly used words or very less frequency words, and how much is the visual or the auditory cues. For example, if I say the word which has got the bilabial movement like mom. So this has got more of a visual cues which are going to be very, very helpful for the patient to repeat or to come out with the response. Overall, we have the different types of approaches which can be used, and the most commonly preferred is the articulatory kinematics approach, and we also have the rate and rhythm approaches and the AAC and other methods. Now among all these things, the focus is more on the articulatory kinematics, where we are trying to improve the articulatory movements and its accuracy. The most importantly, the place of articulation should be accurate in order to produce the target word. Whereas the rate and rhythm approaches are the ones which are going to be designed especially to control the production rate or the speech production rate, so that the patient will have more time interval between the word to word, so that the patient will have the adequate time to plan the speech motor commands, and thereby the patient is going to get better response for the target word. And AAC, we all know that, okay, it's the last option that we can take it up. So I'm not going to focus on this AAC for now. So the articulator kinematic approaches, these are the approaches which focus more on the spatial, that is the place of articulation, and also the temporal movement, the timing. Okay. For example, if I have to say the word cat, okay, the word cat will require, for example, the ka sound will have around 40 to 50 milliseconds duration. The a vowel may have around 50 to 100 milliseconds, and again t may have only 50 milliseconds. So within like 200 milliseconds, the patient has to produce the articulatory movements in different positions. For example, for ka, the patient has to move his tongue to the back of the oral cavity. Then for a, it is the flat, and again for ta, the tongue tip has to rise up to the palate. Now, this continuous process of moving the tongue backwards, flat, and moving up the tip, and this process should happen in a very short duration, and that is what we are going to call it as the temporal movement. So the target of our treatment of this articulatory kinematic approaches is to improve the patient's ability to move the articulators at a rapid rate from one position to the other position, so that the patient will be able to produce the target word easily. And within this, we have some techniques called as 8-step continuum, sound production treatment, and also the prompt. And there are also others given by Darley, Brown, and Aronson and others. Among these, the 8-step continuum can be really useful for most of the patients, and this is going to have a emphasis on the imitation. Like we as a clinician are going to provide the cues, both visual and also auditory cues, and then slowly we are going to remove the auditory and visual cues and make the patient to come out with the target word. And slowly the target or our goal is to make the patient to move to the spontaneous speech from the imitation or repetition. And this is a flexible treatment approach, and which can be used widely across all the severity levels. Now these are the 8 steps that we have in the 8-step continuum. For example, the first one, simultaneous production. When I say simultaneous, it is between the clinician and also the patient. So both of us are going to produce the same target word. For example, if the target word is cat, whatever I am going to produce, the patient needs to watch my articulatory movements, patient needs to hear the word, and simultaneously he also need to produce it. That is with visual cue and also the auditory cues. In the second section, which is called as mimed production, that is we as a clinician, we are not going to give the auditory cue. Okay, we are only going to make the articulatory movement, but without sound. Suppose if the word is cat, okay, cat. So we are only going to make the articulatory movements without sound, and the patient has to produce with sound. So it's a imitation, but slowly we are decreasing the cues. So here we have cut off the visual cues here. And 3, immediate repetition. So you say the word and ask the patient. So that here we are not going to provide the visual cues. It's only auditory cues that the patient should get through and immediately repeat it. And the 4th, successive repetition. First you say a word and then ask the patient to repeat it. Then what will happen? You are trying to remove even the auditory cues. The similar kind of things are going to be done for the reading. reading with delay, and also the answering questions and role play. The 7th and 8th questions or the steps are going to be more useful for the generalization purpose. And any patient, especially like you have the mild to moderate level apraxia of speech, they are going to get maximum benefit with this particular method. And there are some general rules, like you need to go step by step. What do you mean by that? So don't do like the first one and then go to fourth. No, ask the patient to do it properly first one. Once he is able to follow that, then go to the second, then third, then fourth, like that. And the repetitive drill will be necessary to help the patient to relearn whatever the articulatory movement sequences that are required. And try to use more of a functional words, okay? And also the useful words, that is the patient, whatever the patient uses at daily basis. And those things should be initiated in the beginning, and slowly ask the patient to encourage to self-correct. I know the patients are not going to get proper responses immediately. So even if they come out with some incorrect responses, patient should be motivated to self-correct it and again produce the word. The next approach or the treatment technique is what we call it as the sound protection treatment. This is also used for the children with articulation disorders and also the apraxia. And here the focus is on the minimal contrast pairs like cat, bat, okay? The combined components of 8-step continuum is also used. Along with that, there is another additional steps based on the phonetic placement and also the modeling or the imitation things. And it's again structured hierarchically with feedback and modeling. And this has got the strongest evidence that this is a very good or effective treatment approach for the patients with apraxia. And these are the 4 steps that we have it in this particular technique. So the first one is saying the word, showing the letter. It's only one letter that we are going to show, and ask the patient to come out with the words. And then you have the watch me and listen to me. That is like the previous one. You have the visual cues and also the auditory cues. And the 4th one, we are going to teach them the phonetic placement, which is normally done for the articulation disorders. The next one is prompt, which extends for the prompts for restructuring oral, muscular, phonetic targets. This is not very frequently used in India because of lack of certification. Even we don't have certification. But if anybody is interested, yeah, it's a certified program. That means you can use this technique once you complete the certification process. And here, like the previous 2 techniques are based on the visual and also the auditory cues, but whereas this one is going to be focused more on the tactile cues. So it is going to have the placement based upon the movement of the articulators. So depending upon the articulatory placement, what we need to do it, or the position. So we are going to provide some tactile cues with our fingers, and this is going to help the patient to make the appropriate movements to produce the target word. And the clinician acts as external programmer. So we are going to control how the child is going to, whether he is going to open the mouth or close or spread the lips. So each and every consonant or the sound in our language do have one tactile cue what we are going to teach to the patient. And it requires special training and also the licensing, and it is also useful for the severe cases. So it uses a combination of proprioceptive pressure, so the touching of the cues, how we are going to provide to the patient, and also the kinesthetic, that's the movement related cues, are going to be given to the patient. So how do we do it? The clinician is going to provide cues by touching different articulators, the patient's face, and manually guiding the articulatory movements in order to produce the correct target word. These are some videos. Unfortunately, we don't have time, but you can get it through in YouTube. Those are the things that are about articulatory kinematics, so which are focused more on the place and the manner of articulation. The next type of approach that we have is the rate and rhythm approaches. Now these are very simple, and the logic is simple. You give more time for the patient to plan and the program the speech motor movements so that the patient will be better in the responses. So here the target is going to be about the prosody, that is the intonation, rhythm, and all those things, and also the rate of speech and the fluency of the utterances. And this emphasizes on the multisyllabic words and phrase speech. And we have like melodic intonation therapy, metronomic pacing therapy, and contrastive stress tasks, and many other techniques. All of you know the MIT, which is very frequently used for the patient with non-fluent aphasia. The same thing is also used for apraxia of speech patients. Now the idea is that for any one of us, singing like intonation is more easier for the patient compared to the normal speech. And that is the basis or the logic why we are going to involve this particular MIT approach in this. And slowly we are going to shift the patient's speech into the natural speech. So the rationale is singing words is easier than saying them in a conversation for those patients with apraxia or even aphasia. And MIT was designed to capitalize on this by blending rhythm patterns in the normal speech and make it different, which can be also mediated by the right hemisphere. And this can be very useful for both apraxia and also aphasia. So majorly we have got the 3 steps. So initially in the first stage, we are going to incorporate the melodic intonation into our regular phrases. And the second one, gradually shift to saying the words with exaggerated prosody. And third, we are going to produce the sounds or the words or the sentences without varying prosodic aspects. Then we have a metrical pacing and pacing tools. We have the metronomes, hand tapping, finger counting. All these things are used to control the rate of speech, and this is going to help the patient to program the articulatory movements in a proper way. And the simple way to use, all of you in your mobile phones, if you go to either App Store or the Play Store, you have an app called as Metronome. Just click on the metronome, you will be able to download the app, and you can select the number of beats, and that number of beats is going to help the patient to tune their speech one beat, one sound or one syllable that you are going to produce, and that is going to control their rate of speech and thereby getting the better target word. And patients are instructed to synchronize the production of an utterance with a rhythmic tone that is on the app that you can just do it, representing the onset of syllables in a target utterance. The number of tones in a sequence represents the syllable number of the target utterance. And there are also others like keyword techniques, MIPT, voluntary control of involuntary utterances, script training, and these are all also used, but like it is in different contexts, and still the research is still going on to study the effectiveness of this. And we have some biofeedback mechanisms which can also be used, like the electropaltography, which will help us to understand the place of articulation of the tongue position, and electromagnetic articulography. And we can also provide some vibrotactile or visual feedback tools for the patient to get the proper placement of articulation. Now, for example, I think in most of the places we have the doctor speech therapy, in that you have a section for the articulation where it is going to help you to produce the place and manner of articulation can be easily demonstrated. And for the patients with severe apraxia, use reflexive speech like counting the numbers 1 to 10 or greetings, saying hi, hello, and things like that. And elicit speech through gestures or even the mines, and use non-speech oromotor practice when the phonation is absent in the patient. And general tips for the all of the clinicians: identify the goals very beginning, and select some stimulable words. Don't keep some very complex words kind of things in the beginning. You use some simple words which can be visually cued and also the auditory cued to the patient, so that for the starting of treatment you can go with the simple words and slowly you can increase the complexity. And ensure generalization. So don't just limit your treatment to the clinical setup. Make sure the patient is following these steps when he is outside the clinic. And feedback should be tailor-made depending upon each of your patient, and also measure the communicative impact on a regular basis. And in our research, we have the efficacy, proven efficacy for both articulatory kinematic approaches and also the rate and rhythm approaches, which are probably effective for most of the patients. And the intersystematic techniques, which is combined with gestures, they are still in the research stage to provide its efficacy levels. So early initiation with intensive treatment is must for the patient with apraxia, and prioritize meaningful speech activities, and behavioral approaches are going to be central. That is, your speech therapy is going to be the key approach, and you need to make changes as the patient progress. So AOS management is very effective and evolving. Behavioral treatments are our cornerstone, and more research is still going on to refine the strategies of what we have right now. Thank you all, and thank you the organizing committee.
Thank you very much, sir. Even though it is the last talk, you made everyone sit in their chairs. Thank you very much, sir. Now I would like to request the chairpersons to shed the light on sir's presentation.
Thank you very much for your very good presentation. It was very much helpful to therapeutic services. Actually, so many approaches he explained. Really, when we are taking aphasia cases, we know that so much of counseling is required for family, and patient also will feel like whether why I should learn from words and all. That also one of the impact. So according to the patient, we should counsel little bit to understand the family as well as patient, and manner of articulation and place of articulation, oromotor exercise. These are all impactful, and so many goals for management and treatment plans. We should, according to the patient, we should change the plan. So just to go through that, any questions are there, please ask to Dr. Sunil, sir.
Sir, I was looking forward for this presentation. So I'm a prompt level 2 certified therapist, and I use prompt technique with children. So in the 8-step continuum, what would be the mastery criteria to move to the next step?
80%.
80%.
80% is
Okay,
the
sir.
criteria.
And we can use the same approach in prompt technique also.
Prompt also same.
Sure, sir.
But prompt will be with the tactile cues.
Yeah. So is it like after so many consecutive sessions, if the person achieves 80% consistency, we need to move to the next one?
Yeah.
So how can we decide it?
It depends upon like the target words, whatever you are selecting. So based upon the target, in case if the patient is unable to produce the complex words and things, make it more simplified, make it more visually cued words in the beginning stages, and slowly make it. So that's why usually in the apraxia treatment, they they propose to use more of a bilabial sounds and the labiodental sounds, because they are the easiest ways, and the patient will be able to quickly get through the positioning. So better than using the back sounds, it is the anterior sounds are more easier for the patient.
Thank you. Anybody else questions?
Are there any questions from the participants? Thank you very much, sir, for your insightful and informative presentation on the management of apraxia in adults. Your expertise and dedication to advancing clinical practice and research in speech pathology have greatly enriched our understanding. We appreciate your valuable contribution to this conference. With that, I would like to invite Dr. Harini Vasudevan to welcome onto the stage to hand over the token of appreciation to our speaker, Dr. Sunil Kumar Ravi. A round of applause, please. I would like to request our speaker, Dr. Sunil Kumar Ravi, to hand over the chairpersons the token of appreciation. I would like to request Mr. Praveen from Videx Avantis India Private Limited to come onto the dais for your presentation. Praveen. They'll be playing the videos. Please wrap up in less. Actually,
2 minutes video.
just introduce your name and then he'll be playing the video.
Good evening, everyone. This is Praveen Kumar representing Signia and Videx. These are the two short videos about the two products of Signia and Videx.
Can your cus- Can your customers keep doing what they love and improve their hearing, all without anyone noticing a thing? The near invisible Signia Charge and Go IX, the world's smallest rechargeable instant fit device with handy wireless charging to keep wearers in the loop even when they're on the go. Unleash the power of conversation with Silk Charge and Go IX. Signia. Be brilliant. Feel more connected to life as we unveil new angles of natural hearing with the new Widex Smart Rig. Developed in a groundbreaking L-shaped form factor, the Widex Smart Rig places the microphones at an improved angle. This innovative placement enhances the device's ability to align with the user's primary focus, following the direction of their attention. The Widex Smart Rig is available in 5 colors. It offers improved battery performance, allowing longer wear and more streaming time. It comes with a convenient portable charger for charging on the go. And it features newly designed microphone inlets that effectively reduce wind and touch noise in order to make life more comfortable. Building on the strong audiological benefits of Widex technology, the new Widex Smart Rig unveils new angles of natural hearing. Widex. Sound like no other.
Thank you.
With that, we have come to the end of our conference for the 2 days. Thank you everyone for your cooperation. Now, I would like to request Dr. Aparna Ravichandran to come onto the dais, and I would like to request Mrs. Sirisha to come onto the dais to felicitate Dr. Aparna Ravichandran. Thank you very much, ma'am, for your continued support. Now we would like to invite our sponsors for the felicitation process.
Starkey Indian Private Limited, Gayatri Speech and Hearing Clinic, Sampath Garu. Certificates. Certificate. Sonava team. Ramu Garu, Sonava team. Sonava team, please. Sonava team. Ramu. Mind Start Switch and Hearing. Sonava team, Infinio. I for Ramu Garu, Yellandi. Yellandi. Go. Ma certificates ivamma. Certificate. WAS, Signia and Widex. WAS, Signia and Widex. Praveen Garu. Praveen Garu Randi. Here job. Articon. Labat. Alps. Hyphen. Labat, Alps. ALPS, Snail Speech and Hearing Clinic, Snail Speech and Hearing Clinic, Amaravati Speech and Hearing Clinic, Amaravati Speech and Hearing Clinic, VK Healthcare System, HAC, VK Healthcare System, HAC, HAC, Taivas, Taivas, Positive Rehab Center, Positive Rehab Center, Vijayawada Speech and Hearing Clinic, Vijayawada Speech and Hearing Clinic, Medible Technologies, Medible Technologies, Thyrocell, Tresal, next Teja Speech and Hearing Clinic and Advisory Committee Member, APASLPA last year Advisory Committee Member and sponsor Teja Speech and Hearing Clinic, Dr. Durga Prasad Garu. Kiran Speech and Hearing Clinic, Trivikram Speech and Hearing Clinic, Taranga Speech and Hearing Clinic, Alliance GSI, Kiran Speech and Hearing Clinic, GSI Alliance, Trivikram Speech and Hearing Clinic, అయిపోయిందా Taranga Prakash sir, GSA. Advanced Bionics. Rajendra Speech and Hearing Clinic and Riansh Child Development Center. రాజేంద్ర రియాన్ష్ కూడా ఇంకొక మూమెంట్ కూడా ఇచ్చేసండి. రెయిన్బో స్పీచ్ అండ్ హియరింగ్ క్లినిక్. ఇంకో సర్టిఫికేట్. రెయిన్బో స్పీచ్ అండ్ హియరింగ్ క్లినిక్. సారీ, రెయిన్బో స్పెక్ట్రమ్ స్పీచ్ అండ్ హియరింగ్ సెంటర్. అపర్ణ స్పీచ్ అండ్ హియరింగ్ క్లినిక్. ట్రినిటీ స్పీచ్ అండ్ హియరింగ్ క్లినిక్. ప్రైమ్ రిహాబ్ సొల్యూషన్స్. రీసౌండ్ GN రీసౌండ్. Medible Technologies. మనోహర్ గారు. మెడిబుల్ అయిపోయింది. మెడిలైఫ్ టెక్నాలజీస్ మనోహర్. లాస్ట్ అవర్ ప్రెసిడెంట్ సార్ అశ్విన్ ఆడియాలజీ స్పీచ్ అండ్ హియరింగ్ క్లినిక్ అనంతపురం. APASLPA ప్రెసిడెంట్ గారు అశ్విన్ ఆడియాలజీ స్పీచ్ అండ్ హియరింగ్ క్లినిక్ అనంతపురం. I request Dr. Vijay Kumar Narne sir, last year our advisory committee member. ఇద్దరే ఉన్నారు. మేడం ముగ్గురు, శిరీష మేడం సార్ కిషోర్ క్లాస్ ఐటమ్స్ తెచ్చాను. Our APASLPA founder and last year advisory committee member R. Sirisha Garu. Our next elected president and October onwards our APASLPA president R. Sirisha Garu. Very soon we are announced the elections 3 positions. One is elected president, second is secretary post, third is scientific committee. 3 posts are vacant and we are announced very soon. పిల్లలకి ఇచ్చేద్దాం పేపర్స్ ఇచ్చేద్దాం కాదమ్మా అమ్మా
Now it's time to announce the scientific session awards. Are you all excited? Okay. I request Dr. Vijay Kumar Nane sir to come onto the stage and present the awards. Also, I request Dr. Sunil Kumar Ravi sir to please come onto the stage and give the awards. Sir, ikkada. We have the third award prize goes to on title Code Switching and Code Mixing in Interpersonal Communication among Indian Multilingual Youths. Authors Resta, Mariam Fatima, Haripriya, Manidipika, Archana Sastikar, Gigi Matthew from my institute.
No one, they later. Next.
The second prize goes to translation of the IT maze in Telugu language. Supriya, Pranavi, Talari and Padma Priya. AYJ and HH. And the first prize, a case-based perspective on autoimmune inner ear disease. Authors are Tehila, Lenin Babu, Srividya Sherla. HP. And this is all bachelor's category. Now we will announce professional and masters together a category. The third award goes to Speech and Language Profiling in Parietal Glioma, Insights from a Single Case Study. Varshita M, Sri Pavitra, Susan G. Uman from HK, Helen Killers. Ma'am. And the second paper, second award, the role of swallowing and vestibular rehabilitation therapy in post-stroke aphasia, a multidisciplinary intervention study. And the authors are Sucharita, Kirti Prasanna, Vikas and Gopi Venkatesh.
We welcome Gopi and Sucharita onto the dais.
And the last but not the least, the first award goes to Impact of Negative Vocal Behaviors on Untrained Singers, a survey. Renis Karya Pavit E. Kumar from Helen Keller Institute.
Encouragement award.
Now also we have participation awards for all the presenters. It is for your encouragement to continue for more in future. The first award goes to clinical practice trends in Gestlat's language. This is already went. Harikishnan. Haripriya ma'am and Harikishan.
Next.
Again the same. Second also. Second paper also the same. Harikishan. Hare Krishna. Maybe effectiveness of voice therapy in rehabilitation. Speech and language. Effectiveness of voice therapy in rehabilitation after total thyroidectomy. A single case report. Voice dysphoria, a comprehensive assessment profile. Who all presented, can you please come on? Please come forward. I think Varshita, there? You have already taken. అందరూ వెళ్ళిపోయారు మ్యామ్. Thank you so much, sir, for evaluating the papers and for your time. Even your presentations have been delayed because of all these glitches and all. Thank you very much, sir. Thanks for your support.
Thank you, sir.
Thank you, sir. And if anyone haven't received from HK, can you all just come and take? Like we haven't announced, but can you please come and take for the presenters? Please come. I think you all have presented, no? Come.
Can you please stand up? We'll sing the national anthem. అది మనం చేసుకుందాం మళ్ళా ఇది అందరూ వెళ్ళిపోతారు క్లోజింగ్ సెరమనీ
పాట ఏం పాడాలి జనగణమన
యోగాడే కదా జనగణ మన దిన మేడం లేవాలి జనగణ
attending. So now we will close our conference with national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाता जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय हिंद जय बोलो भारत माता की thank you all for coming
And I would like to thank Sucharita, Aparna ma'am, Lavanya, Sujita, Trivikram, సంపత్, సుధీర్, శ్రీధర్ గారు, కీర్తి ప్రసన్న, విజయ్ శంకర్ గారు, శ్రీధర్ గారు, థ్యాంక్ యూ, ప్రకాశం గారు, నరేంద్ర గారు, మోహన్, క్రిస్టోఫర్ గారు, మోహన్ గారు, రవితేజ, ప్రవీణ్ గారు, వాసు గారు, ఏంజల్, నిసి,